important group of disorder, that is mood disorders, also known as affective disorder. So I told you mood and affect are different terms. They are related with emotion, but when we discuss the disorders, we use these terms interchangeably. Okay, so mood disorder or affective disorder, right? So as the name suggests, what is the abnormality? There is abnormality of mood. Okay, so there is problem in the mood of the person or the affect of the person, right? Now, before discussing and starting the disorders, I want you to understand some basic concepts. Okay, when I talk about mood, okay, just understand. If you don't write, it's okay. Just understand this. So we say mood can be of two abnormal states can be there in mood. Either the mood can be sad or depressed. Okay, so there can be a depressed state. So two mood states we're talking about. So this concept will help you, grasp this topic. Okay, so either a person is sad or the person is excessively happy. Okay, being happy is not a disorder, but without any reason and abnormally happy is. Okay, or sometimes person is irritable. Irritable means getting angry on small things. Okay, very easily patient becomes angry. Okay, so patient may be happy or irritable. Okay, so these are the two mood states, two abnormal mood states, right? Now, based on this mood states, when we talk about mood disorders, okay, so based on these mood states, we'll talk about important mood disorders. Again, some mood disorders will be of two types. Okay, in one, the person is depressed. Okay, or the person is sad. Okay, so person has episodes of sadness. Person may have one episode, patient may have multiple episodes, but he is only having sadness. Okay, so this is depression. Right? This is depression. Okay. So when I'm talking about depression, let us say, so this graph I'll make multiple times in this topic. Okay, let us say the below is the depressed phase and the above is happy phase. The line, this line, middle line is the normal phase. Okay. So if the person is having depression, he is having problem at the lower pole. Okay. So his mood is sad. It may be one episode or it may be multiple episodes. Right? It may be one episode or multiple. When I'm talking about episode, that means in between two episodes, let us say these are the three episodes. In between episode, you can see the patient has become normal, isn't it? So patient had depression. After few weeks or few months, he became all well, completely well. Then again, after few months or few years, he again had an episode, again had a dip. Again, the mood became low. Okay, so these are basically, please understand, these mood disorders are episodic illnesses. Predominantly, they are episodic illnesses. So this is what I mean by episodes. Everyone understood? When I say there is a past history of episodes, so that means in the past, it may be few months back or few years back, he had some episode of similar illness or some other illness. Okay, so in between he's all well. So this is one illness. Second illness is what is known as bipolar disorder. Second illness which we are going to discuss will be bipolar disorder. One is depression, depressive disorder. You can say depression, depressive disorder, many names you can give. Okay. Other is bipolar disorder. In bipolar disorder, what is happening is there is problems at both the poles. Patient may have episode of depression, then patient may have episode of mania or hypomania. We'll discuss what is mania, what is hypomania. Okay, don't worry, we'll discuss all of these. So patient can have multiple episodes. So now, are you able to appreciate why we are calling it as bipolar disorder? Are you able to appreciate? Because you can see the illness is occurring at both the poles. That is why bipolar. But at one time he will be having one symptoms. Okay, suppose the patient currently is having manic symptoms. In the past, there was history of depression, also mania, also again depression also. Again, this is episodic. You can see, you can appreciate that in between, patient has become all well. Okay, so this is bipolar. So in that sense, this depression will become unipolar depression, isn't it? Isn't it? This becomes unipolar depression. And someone who is having depression in this illness will be bipolar depression. That is the difference. Okay, we'll discuss them one by one. I hope you understood this concept, because understanding is very important. Very good questions have been asked from this topic, and again, many clinical questions you can expect from this topic. So we're going to discuss a lot of clinical scenarios, right? So let us start. So the first disorders which we are going to discuss, yes, for someone's happy, for someone's sad, yes. Major depressive disorder or simply depression. Okay, or simply depression. Okay, or depressive episode. Okay, that is why I told you it is also known as unipolar depression, right? So there are only depressive episodes, So what three things you need to understand: how to make the diagnosis of depressive episode, how to make the diagnosis of manic episode, how to make the diagnosis of hypomanic episode. If we understand these three things, we'll be able to make the diagnosis whether it is depressive episode or bipolar illness, right? Okay, so let us start with depression. Okay, so let us start with the etiology. Again, this is very important. There was, yeah, अच्छा, slide. Okay, okay. There was a question in 2021 on the treatment. A direct question was there. They had asked mechanism of action of one of the drugs. Okay, so we'll discuss that. Okay, everyone has written. Shall we continue? Right. So etiology. Again, etiology is very important in this. So one very important etiological factor are the neurotransmitters. This is very important. You understand this concept, a lot of treatment will be, you'll be able to understand the treatment. Okay, understand this. So 5-HT is very good. It is serotonin. Now NE is norepinephrine and DA is dopamine. Two important neurotransmitters I want you to remember at least: serotonin and norepinephrine. There is a decrease in serotonin, decrease in norepinephrine. Okay, decrease in serotonin, decrease in norepinephrine. Okay, in the patients with depression. Some group of drugs, can you tell me, used in depression? One is SSRI. I will discuss what is SSRI. Selective serotonin reuptake inhibitor. Don't write it full form, just write SSRI. I'll tell you in the end when I will talk about management. Selective serotonin reuptake inhibitor. What this group of drug do? They increase serotonin. So if you are using some drug which increases serotonin, that means what is happening in the depression? Serotonin is getting decreased. So we are using drugs to increase it, right? Then there is another important group of drug. Yes, TCA is there, and also SNRI is also there. What are SNRIs? Serotonin norepinephrine reuptake inhibitors. What these drugs are doing? They are increasing serotonin. I'll write it again. They increase serotonin and they are also increasing norepinephrine. So what must be happening in the illness? It must be decreased. So you can correlate like this so that you are able to remember. Okay. Also, it is also seen that even dopamine is getting affected. Even dopamine is getting decreased. But if there is a question in which you have to choose two neurotransmitters, you can choose the first two. Okay. Of course, dopamine is also getting affected, but you have to choose between, if there are, options in which you have to choose one where there is norepinephrine and serotonin, choose them, right? So this is very, very important. Please highlight this. So question based on this was asked. Okay. So they had asked one of the SNRIs. Okay. Now again, genetic factors. I told you in psychiatric illness, many factors play a role. So genetic factors also play a role. Many times you may find a positive family history. Please understand, it's not always that you will have a family history. Okay, it's not that in all patients you will find family history present, but many times you will find. Okay, many a times you will find a positive family history. Okay, so there are many genes which have been identified which may cause depression, right? Now, next and the last important factor which I want you to remember is cognitive theory of depression. Okay, cognitive theory of depression. Okay, so basically, this cognitive theory was given by Aaron Beck. Aaron Beck. Okay, so simple question maybe cognitive theory is for which disorder? Just like dopamine hypothesis was for which condition? Dopamine hypothesis. Anyone? There is increase in dopamine. What was the disorder? Schizophrenia. Similarly, they may ask cognitive theory is for which disorder? It is given for depression. So basically, simply it means the cognitive means thinking, thought. Okay, so cognitive theory says that here the thinking is problematic, the thinking is disturbed or distorted. Okay, so person who has depression has a lot of negative thoughts, is thinking a lot of negative things. Okay, so they say that patient develops negative automatic thoughts. Okay. Okay, negative automatic thoughts. So all of us are having thoughts which are popping up on their own. We have automatic thoughts. Normally all of us have automatic thoughts. But predominantly in these patients, these automatic thoughts are negative. They develop negative feelings. Okay, so this is cognitive theory of depression, which was given by Aaron Beck. Okay. Yeah. So again, you can write it down. This is very important. One more important point you can add here is a lot of times hormonal changes are associated with depression. Yeah, it was given by Aaron Beck. Okay, a lot of hormonal changes occur. So many times you will see post-pregnancy patients develop, depressive symptoms. A lot of hormones play a role in depression. Okay, especially one important hormone one important condition I want you to remember is hypothyroidism. Hypothyroidism. Okay, again, so there are many hormonal factors, especially hypothyroidism. Okay, in fact, patients who have subclinical hypothyroidism may also develop depressive symptoms. Okay, so one thing you can remember here is thyroxine or the thyroid hormone. Okay, thyroxine is sometimes used as an add-on therapy. Is used as an add-on therapy. This is again an important point. Thyroxine is used. Patient is not having hypoclinical hypothyroidism. Patient is not having clinical hypothyroidism. Still, we have seen that patient who are having depression, we are giving medicines. Let us say antidepressants we have given. Antidepressants are not working. Sometimes adding thyroxine can help the patient, can help improve the patient. So you may get a question, which of the following can be used as an add-on therapy? Thyroxine may be there in the option. So please remember this. We can use sometimes, not in every case, especially if patient is having subclinical hypothyroidism, those patients may show benefit in depressive symptoms also. Okay, so this is important again. So this is, you can put a hashtag, this may be a new question. These concepts are being asked nowadays a lot, so please remember this. Simple question. There were 2 questions on depression this time. There were 2 questions in June 2021 in this topic. Okay. So you can expect more questions from this. A lot of clinical questions can be asked from this. Okay. Now, coming to the epidemiology. Depression is more common in males or females? How many say males? Females? Yes. Yes. It is more common in females. In fact, twice more common than males. Okay. Especially middle-aged females. Especially middle-aged. Okay. So there was once a question, depression is more common in young male, young female, middle-aged male, middle-aged female. Answer is middle-aged female, right? Out of all the psychiatric illnesses, depression is the most common cause of suicide. Out of psychiatric illnesses, I'm not saying overall. I'm saying if you compare all the psychiatric illnesses, depression is the most common cause. Okay, so don't take this message that in suicide, depression is the main cause. No, I'm saying out of all the psychiatric illnesses, right? Depression is the most common cause. Everyone has written this? Yes, sir. Now let us come to the diagnosis. How do we say that someone is having depression? Okay, let us say someone didn't do well in any exam, someone got suspended from college, lost his job, feels sad. Is it depression or is it not? We don't know. We have to see the symptoms. We have to see the duration. Okay, so everyone who is feeling sad is not depressed. Please understand this. Okay, so when do we diagnose depression? So again, according to DSM-5, so what is the duration for these symptoms should be present for how much duration? At least 2 weeks. It could be months together, but minimum 2 weeks. For minimum 2 weeks, the symptom should be present. Minimum 2 weeks. Okay. Same goes with ICD-10. ICD-10 also agrees. In some disorders they agree with each other. Okay, so they say, okay, let's call it as 2 weeks. Okay, let's call it as 2 weeks. Right. So let me give you another mnemonic here to remember the symptoms for making the diagnosis. The mnemonic is I miss swag energy. Okay, so the mnemonic is itself telling you certain symptoms, right? So the mnemonic itself is telling you certain symptoms, what is happening in depression. So I miss swag energy, right? So what is I here? Interest. Remember? So a 30-year-old female since 2 months come to us and says, doctors, in the past 2 months, I'm not enjoying things which I would enjoy before. I would enjoy watching movie. I would enjoy spending time with my friends, with my family. Nowadays, I don't feel like enjoying any of those. So this is, yes, so there is decrease in interest, which is known as anhedonia. We already have discussed anhedonia. Very good. Right. And since it's a mood disorder, so what is abnormality is present? Mood abnormality will be there. So what is the mood here? It is sad or it is depressed. Okay. So mood is sad or depressed. Right. Okay. Okay. Then next symptom I is inattention or lack of concentration. Okay, lack of concentration. So patient complains, the 30-year-old female, she's saying, doctor, nowadays I forget where I've kept the keys or forget, important things. I'm making food, I forget to put salt. I'm talking to someone, I forget what I'm talking. So because there are so many things which are occurring in the mind, so many thoughts, so patient is not able to pay attention to the immediate things. Okay, so they come with us, come to us and say, doctor, I feel that I'm forgetting things. It's not that forgetfulness which we had discussed in dementia. It's not that. It's because of inattention, lack of concentration. So what it is also known as pseudo dementia. So in this one, I'm giving you certain terms which you'll not find. You will come across pseudo dementia is seen in depression, but I'm trying to correlate here itself so that you remember. Okay. So pseudo dementia is seen in pseudo dementia is not a true dementia. It's not a cognitive impairment. It's because of lack of concentration or inattention. Pseudo dementia seen in depression. Once, a long time back, this question was also asked. Pseudo dementia seen in, so they've given various Alzheimer's, frontotemporal dementia, depression was also there in the option. Okay. Then S is sleep. So there are sleep problems or sleep disturbances. Both type of sleep disturbances can be seen. Okay, so there can be decrease in the sleep, which is known as insomnia. Okay. Especially one particular type of insomnia I want you to remember. The patient says, doctor, I get up 2 hours before my normal time. So earlier I would wake up at 6 o'clock. Nowadays I wake up at 4 o'clock. Okay, so one specific insomnia is very commonly seen. Early morning insomnia. Okay, so remember this. Okay, so it is basically waking up 2 hours before. Okay, 2 hours before. Patient is waking 2 hours before his usual routine time. Okay, so again, early morning insomnia is characteristically seen in depression, right? So one change can be decreased sleep, that is insomnia. So majority of the patient will complain of this, but some patients, some small group of patient also says in depression, doctor, nowadays I'm sleeping a lot. I'm sleeping a lot. Even in daytime, I feel very sleepy. So sometimes there is also increase in sleep. Okay. So sometimes there is also increase in sleep, which is known as, very good, hypersomnia. Hypersomnia. Okay. Important. Okay. So majority of the patient will say there is decreased sleep, but some may say the doctor, my sleep has increased. Okay. Now, next is S is suicidal thoughts or suicidal attempts. Patient may complain that doctor, because there are so many negative thoughts, doctor, I feel my life is, nothing, I'm good for nothing, I should end my life. Such negative thoughts may occur in the patient. Okay, so this suicidal patient, again, in psychiatry, there are very few conditions which can lead to death, which can lead to mortality. This is one of them. It's an emergency. Suicidal thoughts or suicidal attempt in a patient, it's an emergency. You have to take strict and immediate action. Okay, we'll discuss how to manage. Okay, then W is weight. Okay, or you can say appetite. So again, in majority of the patient says, doctor, my weight is getting decreased, or my appetite, because my appetite it's getting decreased. I don't feel like eating anything. Okay, so there is decreased weight or decreased appetite. I don't feel like eating anything. The patient will say, doctor, earlier I was eat 2 chapatis, now I eat only half. Sometimes I skip the meal. I don't feel like eating. Okay, so majority of the patient will say that there is decreased weight or decreased appetite. But sometimes again, patient may complain the opposite. Doctor, I feel like eating so much. How many of us, when we are sad or we are feeling not good, we just go in the fridge and just eat anything which is there. Okay, emotional eating. So some patient may also say, doctor, I eat a lot, so my weight is getting increased or my appetite is increasing. Okay, my appetite is increasing. Okay, so important. Okay, then next is A. So how will be the activity levels? Activity level, yes, usually it is decreased. Some patient it may be increased. Okay, in the sense that they are very agitated, very restless. They come and they feel I'm not able to sit. There is a lot of agitation as well. So sometimes patient will say I have stopped doing activities. but sometimes patient is also severely agitated. They're not able to sit. They are very restless. Okay. G is feelings of guilt. Okay. So they have, some patient may develop a lot of guilt or worthlessness. Feelings of worthlessness. Worthlessness, I am worth for nothing. Negative things or thoughts about themselves. Okay, they have guilt, I have done sin. I am a sinner. I am a very bad father. I am a very bad mother. Such thoughts are there, or they have, I am good for nothing. Worthless thoughts may be there. Okay, and the last is energy. What will be the energy levels here? Down. The energy is low. They are easily fatigued. Easily they get fatigued. So easily fatigability is there. So they will say, doctor, I get tired very easily. So whatever work which I used to do, I'm doing the same work and even less, but I get tired very easily. Okay. So these are the symptoms. These are the symptoms of depression. Okay. So how to make the diagnosis? So there should be at least one symptom from the first two. Okay, so there should be one symptom from the first two and 4 or more symptoms of the rest. Okay. Now please don't start counting in the question. I'm telling you, this is the criteria, but when a symptom, they are telling you, 30-year-old female, since 2 months, feeling sad, decreased interest, decreased sleep. So you are able to get that overall idea they're talking about depression. Okay. It's not very hard and fast. You have to count the number of symptoms. Okay. So there may be 1 or 2 less or more, just so please remember, but this should be there. Decreased interest and or problems in the mood. And usually mood is always there. But the criteria is any one should be there. Usually mood will be there. When you are given the question, they will say patient is feeling sad. And these symptoms should be present for at least 2 weeks. Then you have to make the diagnosis of depressive episode. It can occur for months together. Sometimes, it is, when I say episodic illness, I'm saying it is the nature of the illness. Even if I don't treat the patient will become all well. A depressive episode naturally will go by 6 to 9 months. But please understand how much disturbing it is for the patient. So that is why we treat, so that we, escape the patient from that agony. Okay. So these are naturally only their episodic illnesses. They would go up. Okay. So this is how we make the episode of depression. So this 20-year-old female patient come with complaints of decreased mood, sad mood, decreased interest, decreased energy, problems in sleeping, decreased appetite since 2 months. Diagnosis, depression. Okay. Now, sometimes let us say this patient who has come to us, so this 30-year-old female patient who has come to us says, so she has come to us with this episode when she is 30 years of age. Okay, so this is the current episode which we are talking about. When you take a history, she says, doctor, when I was 20 years of age, I had a similar episode which lasted for 6-7 months. In between, I became all well, and now this is the current situation. So this current episode is the second episode. This was the first episode. Okay, so if person comes like this, then what diagnosis we make? We say it is major depressive disorder recurrent type, or simply you can say recurrent depressive disorder. Okay, some patient may have just one episode and throughout their life they may not have any other episode. Some patients can have repeated episodes. So we call it as recurrent depression. We call it as recurrent depression. Okay, so it is recurrent depression, right? Recurrent depression means there are 2 or more episodes. Okay, so there are 2 or more episodes of depression. Okay, everyone understood this? So it can occur repeatedly. Okay, it can occur repeatedly. Now we made the diagnosis of depression. Okay, we made the diagnosis of depression. sometimes a patient, you can write, then I'll explain this. So everyone write it down. Everyone has written? Okay. Now sometimes, so we have made the diagnosis of depression. Please understand, we have made that patient is having depression. Sometimes along with depressive symptoms, there are certain unique features there in the patient for which we add some specifiers. We say patient is having depression with certain characteristic or unique features. Why we do so is because this helps us in management. Okay, so let us see what kind of specifiers we're talking about. So we add certain specifiers. Okay, you can see the previous slide. Okay, so MDD is major depressive disorder. This is the diagnosis. Then we are discussing certain specifiers. First, an important specifier which we'll discuss is psychotic symptoms. Psychotic symptoms. Right? So patient has depression, and now along with this, patient has developed certain psychotic symptoms like delusions, hallucination. Remember one delusion we had discussed, which may be seen in depression? Which was that delusion? Delusion of nihilism. I don't exist, my body does not exist, people around are dead, world is dead. Please understand, even other delusions can also be seen. Even so, I am not saying depression with delusion of nihilism. I am saying with psychotic symptom. That means other delusions or hallucination can also be seen. Okay. Now, so what is the difference? Let me show a table and ask you. Let's discuss. Yes, Cotard, very good. Let's see, and let me see if you are able to tell me. Let us say this is 7 months duration. Let us say this is 7 months duration. Okay, right? So a patient develops certain symptoms. Okay, these are the schizophrenic symptoms or psychotic symptoms, and for some time patient also developed depressive symptoms. Okay, on the other hand, this second patient since 7 months has mood symptoms or depressive symptoms, and also now has for some time has psychotic or schizophrenia like symptoms. Okay, we're able to appreciate both these patients. Let us say this is patient A, let us say this is patient B. Okay, are you able to appreciate? See, so both we are saying 7 months. Just to compare, I'm saying 7 months. Okay, and in patient A, symptoms started with which? Schizophrenic or psychotic symptoms. In between, patient is having some mood symptoms. Predominantly the symptoms are schizophrenia. Okay, while the second one, patient started with depressive symptoms, and in between patient also developed for some duration psychotic symptoms. So diagnosis of one is, what is the diagnosis? Schizophrenia. Very good. Remember I told you even in schizophrenia mood symptoms can develop. Remember? And it's a good prognosis. Okay, this is what I'm talking about. Predominantly patient is having schizophrenia. And what is there in the second patient? Predominantly patient is having depression and also has developed some psychotic symptoms. Okay, so this is depression with psychotic symptoms. Okay, so all of us, so patient, this 30-year-old female patient who was saying, doctor, I'm since 2 months I'm feeling sad, depressed, I'm decreased energy, decreased sleep, decreased appetite. She also starts thinking that I am dead. Okay, I am a sinner. I have done, so, and that conviction is you cannot change. Okay, or she starts hearing voices of his neighbor who are saying that I am good for nothing. So such kind of symptoms can be present. So this is depression with psychotic symptoms. Now, why we need to understand this is because when I manage this patient who has depression with psychotic symptoms, of course, I will start with antidepressants, but I also need to start antipsychotics. So this is very important for your management. They may give you a question, patient is having these symptoms, along with this patient is also suspicious. Management. One option, let us say they give SSRI. Second option, they give SSRI plus antipsychotic. You will add antipsychotic. So please put a hashtag why this is important. Nowadays they are asking such questions. So management becomes very, very unique and very important. Okay. So everyone understood this? Right? Clear? So management, please put a hashtag over this point. You need to see in the question whether other symptoms are there or not. Right? Second is, we have already discussed patient, as I told you that catatonic features can also be seen in mood disorder. It was seen in schizophrenia, good. In fact, if you ask me, catatonic symptoms are more common in mood disorder. In fact, so catatonic symptoms are more common in mood than schizophrenia. Okay, so catatonic symptoms. So don't take this message that catatonia is seen in schizophrenia. Okay, catatonic symptoms are more common in mood disorders, especially depression, than even schizophrenia. So you can find any catatonic symptom you remember. Any catatonic symptom? Mutism, baxi-flexibility, echolalia, echopraxia, mannerism, stereotypy, all those symptoms. 3 or more present will say patient is having catatonic symptoms. So diagnosis is depression with catatonic symptom. In the treatment, of course, we will use antidepressant, but along with antidepressant, we should also add drugs like which benzodiazepine? Good, lorazepam. Okay. Right? And sometimes we may also require ECT. Okay, sometimes we may also have to give ECT. ECT we'll discuss in the end, certain important indications. Yeah. Okay. So now you can appreciate why this is important to know certain these specified. This psychotic symptom one, you can put a hashtag, you can expect a question. Maybe in the next exam or it will come. In the next 1 or 2 years, you will expect one question from this. Because in depression, 2 questions were asked this time, both related to management. Okay, so management is very, very important. Okay. One question about lorazepam, they did not ask it was schizophrenia or it was depression. They just given patient is having catatonic symptom. They had asked management. Few years back, this question was also asked. So catatonia itself is again very important. Okay. Everyone has written? Yeah. Then next is with postpartum onset. Postpartum is after pregnancy. So during delivery, so if patient develops depression during pregnancy or within 4 to 6 weeks of delivery, okay, some books say 4 weeks, some say 6 weeks, so I've given you both. 4 to 6 weeks of delivery. Then we say this is post-depression with postpartum onset, or simply we can say postpartum depression. Right? This question was asked in 2019. This was a 2019 question, a direct question. A female has delivered a baby, live baby, and 5 weeks later she developed symptoms of irritability, decreased mood, suicidal thoughts. Okay, so the answer was postpartum depression. Please understand, postpartum, 3 terms I want you to understand here. Postpartum blues, feeling blue. You must have heard, I'm feeling blue, I'm feeling not that happy. So these are basically temporary phases. In fact, it is seen 75 to 80% of the females after delivery develop some sad or depressive symptoms. But that is not depression. That is temporary. So one of the option was postpartum blues. But in the question they had given suicidal thoughts. Suicidal thoughts will develop in depression. Postpartum blues is temporary. It will resolve on its own. You just have to be supportive to the patient. Everyone understood? So it could be postpartum blues. So after delivery, or in pregnancy or after delivery we are talking about. Okay. Then postpartum depression we have already discussed. It is like the depression we know. All the symptoms will be there. Okay. And sometimes patient along with this may also develop postpartum psychosis. In psychosis, patient will develop psychotic symptoms like delusions, hallucinations. Patient will say, no, I never delivered a baby. Patient will develop this false belief, no, this baby is not mine. When such symptoms are occurring, that means patient has a false belief. It's a delusion. Patient may say that I am hearing voices that kill this child. Okay, so you have to be very careful. We don't say that you have to separate the baby and the mother, but you have to not leave them alone. Sometimes patient may take such action. Okay, so you have to be careful. So you have to see when it is depression, if only depressive symptoms are there. When along with depressive symptoms may be there in the patient, but patient has also developed delusions or hallucinations, then you have to say it is postpartum psychosis. Okay. Everyone understood the difference between these three? Very important. So postpartum blues will never have suicidal ideations. It is just mild form. Okay, just the spontaneously symptoms will resolve, go away. Okay. So please remember this again. This question was asked in 2019. Such questions are being asked nowadays. Please remember this. Okay. Now let's come to the treatment. Now, when we'll discuss treatment, we'll discuss in two ways. We'll discuss drugs. We'll discuss psychotherapy. Okay. We'll discuss medicine. Then we'll discuss psychotherapy. Now, first let us know. So there are many drugs which are used. Drug of choice are SSRI. Drug of choice are SSRI. SSRI are selective serotonin. So basically, from the name, can you appreciate? So reuptake inhibitors. So can you appreciate, so what they are doing is, so what these SSRIs are doing is, so there is in the synapse, there is serotonin. They are preventing the uptake. That means they are increasing the concentration of serotonin in the synapse. Okay. So drug of choice are SSRIs. Okay. So you can make this small, so we know what were the neurotransmitters which were involved. Norepinephrine, dopamine, right? Please understand drug of choice is SSRIs. Drug of choice is SSRIs. Okay. So which drug is increasing? Which serotonin only? It is SSRIs. SSRIs like sertraline. Can you name other SSRIs? Sertraline. Any other? Fluoxetine. Very good. Fluoxetine. Very good. Citalopram. Then citalopram. Postpartum blues is when patient is having just transient symptoms, mood symptoms, irritability, sadness, that goes away. That is temporary, it goes away on its own, does not require any treatment. Okay, after delivery. Okay. Paroxetine. Okay. Paroxetine, right? If you want to add one important point here, paroxetine is contraindicated in pregnancy. P for paroxetine, contraindicated in pregnancy because of cardiac defects. It can lead to cardiac defects in the child. Okay, paroxetine is contraindicated in pregnancy. Okay. So basically what we're talking about antidepressants, right? Okay. So one group is SSRIs. SSRIs are the drug of choice. The drug of choice. Okay. Then there are certain drugs which affect both. Certain drugs which affect both. What is this drug? SNRI. SNRI. From the name itself, you can see what are SNRIs? Serotonin, very good. Serotonin, norepinephrine, reuptake inhibitors. Reuptake inhibitors, SNRIs. Okay. Don't think it is affecting both the neurotransmitters, so it is a better drug. No. Drug of choice is SSRI. Okay. First line drug. Okay. Various SNRIs you can write. Venlafaxine, desvenlafaxine, venlafaxine, desvenlafaxine, duloxetine, milnacipran. Okay. SNRIs, venlafaxine, desvenlafaxine, okay, desvenlafaxine, milnacipran, duloxetine. This was the question which was asked in June 2021. They asked, a person is having depression, psychiatrist started a drug which increases serotonin and norepinephrine. Which the drug could be? One of the option was venlafaxine. So it affects both. Right? Please remember, drug of choice is SSRI. Please remember this. Okay. Then there may be certain drugs which affect both norepinephrine and dopamine. One important drug I want you to remember here is bupropion. It's a NDRI. It's a NDRI. What is NDRI? Norepinephrine dopamine reuptake inhibitor. Bupropion will also discuss when we'll discuss substance. There was a question, which antidepressant is used for smoking cessation? Right? Bupropion. So again, this is one drug which we'll again discuss, bupropion. Okay. So questions are coming from these topics again and again. Please remember this. There are other drugs also. It's not that these are the only drugs. There is also TCAs, tricyclic antidepressants. There are many drugs. Okay, drugs like amitriptyline is a TCA. Okay, those are, but they have, side effect profile is high. Okay, a lot of side effects are there. Okay, so they are less commonly used. Okay, TCA means tricyclic antidepressants. Okay, they also increase serotonin and norepinephrine. Okay, so there are many drugs. Please remember. Please mark this, highlight this, management, very, very important. So one question, so two questions in the from the management of depression were asked this time. Okay. So duration is, so when we have to treat, so if it is the first episode, so everyone has written this? Okay, write it down. Suppose patient comes with the first episode. You start with antidepressants. Okay. So duration of treatment. Okay. Suppose patient comes with the first episode. You started with medicine. Patient shown improvement. Okay. Now please remember, can anybody tell me how much time it takes for the onset of action of these drugs? Onset of action. Onset. मतलब कितने, for how you start a drug, what time will you see the effect of the drug? We say it is 3 to 4 weeks. But but understand this, clinically we see even in within one week also we see a lot of changes. But the book says that it takes 3 to 4 weeks for the onset of action. That it is not immediate. You need to understand it's not I start an antidepressant, patient will say, I should expect improvement with second or third day. No, you have to tell the patient it will take time. Okay, so onset of action takes 3 to 4 weeks. But clinically we see within 1 to 2 weeks a lot of patients show good improvement. Okay, or they start to respond to the medicine. Okay, so duration of treatment, when the patient in the first episode you started an antidepressant, patient improved. So patient will ask doctor, for how long should I take the medicine? You have to tell the patient. Otherwise, what happens? Patient shows improvement in the first month, they stop taking medicine. I am all well now. I don't require treatment. 2 months later, they again come back. Sir, I am again having depression. Okay, so in first episode, you should continue medicine for 6 to 9 months. So basically, we are covering that. We know depression takes 6 to 9 months naturally. So we're trying to cover that so that after that we stop. Because sometimes there are relapses. Okay, and if there are more, if there are 2 or more episodes, then again it can take longer, maybe 1 year, 2 years. Okay, it can take longer. But remember this, at least remember this. Okay, so this was about the medicine. Please see if you missed anything. You can expect a lot of questions from this. Okay, yeah, 1 to 2 years you can see, but it's not very hard and fast. Sometimes it depends on the patient profile. Okay. Now, next is, everyone has understood this. Next is psychotherapy. Psychotherapy, or simply we what we know as counseling, talk therapy. Okay. So best psychotherapy for depression is, anyone? Very good. CBT, cognitive behavior therapy. Cognitive behavior therapy, CBT. It is the best. So there are many therapies which we have. It's not that we just talk with the patient. We have proper sessions with the patient. Okay. So we told discuss cognition is cognitive theory said that there is problem in cognition, right? So we are trying to improve the cognition. Cognitive behavior therapy. Okay. Now, so please understand, if the symptoms are mild symptoms. So mild means that the symptoms are not very affecting the patient. Patient may say, doctor, I am able to do work, but I am having the symptoms, but I am able to do work. Okay, so if the symptoms are mild, we say that we can prefer CBT over antidepressants. Okay, you can prefer CBT over antidepressant. You can consider starting CBT. Many times patient shows improvement, and then you may not have to start antidepressant, because if you start antidepressant, you have to continue it for at least 6 to 9 months. Please understand this. Okay, but if the patient is having moderate or severe illness, then you have to start antidepressant. Along with this, you can start CBT, but antidepressants are required. Very important. Okay. So if patient is having mild symptoms, it could be even in pregnancy, lactation, anywhere. If it is mild symptoms, you can start with CBT. But if it is moderate to severe, you need to consider antidepressant. Even if the patient is pregnant, lactating, you need to consider antidepressants. Okay, which antidepressant you should definitely avoid in pregnancy? Paroxetine. Okay. So this was the question which was asked in again June 2021. Mild depression. Some recall student says that it was written mild depression. Some say it was mild depression and the female was lactating. So it was lactating, but the symptoms were mild, then CBT. Even if it was moderate or severe depression and patient is lactating or pregnancy, then also you need to start antidepressant. But in mild cases, yes, you can take a trial of CBT. Okay, so this is important, right? So this again is very, very important. Now, then there are certain other modalities. Then there are certain other modalities. One of them is very important. Suppose let me ask you this scenario. A patient is pregnant, is having depression, is having suicidal thoughts. Okay, patient is pregnant, she is having depression, and she has also developed suicidal thought. Doctor, give me 10 minutes alone. Just leave me alone for 10 minutes in this room. I want to end my life. This is how the patient says. So patient is severely suicidal. She wants to end the life. You cannot let the patient go. It's the emergency. What will you do? How many if we say we'll do therapy? Therapy, no one will do therapy. No one will try to counsel this patient. How many if we say we'll start medicines? Medicine. How many if we say we will do ECT? Okay. Yes. Please remember, yes, I will do counseling. I try to counsel the patient. Yes, I will do that, but it is not the treatment of choice. I can start medicine, but it's emergency. Medicines will take how much time? 3 to 4 weeks. I cannot wait that longer. I will give ECT. Please don't think that patient is pregnant, we cannot give ECT. We can. You just have to, keep obstetric rings with you. Also, fetal monitoring should also be there. In fact, it is a very good therapy. Sometimes medicines have side effect, teratogenic effect to the baby. ECT is again a modality which can be used. So don't think that pregnancy, how can I give ECT? No, you can give ECT. Okay. Again, if patient is having depression along with catatonia, again here also I can give ECT along, of course, antidepressants can also be added. So ECT has many uses. Okay. So one was ECT. Second is there is a modality known as vagus nerve stimulation. Vagus nerve stimulation. Okay. It is used for resistant depression. It is used for resistant cases of depression or treatment resistant depression. What was the drug used for treatment resistant schizophrenia? Clozapine. Okay, in certain resistant cases we can use, it's a surgical procedure, vagus nerve stimulation, so it's not psychiatrist who will do, the surgical team will be doing this. Okay, so what we do is the left-sided vagus nerve, cervical vagus nerve. Okay, we put an electrode, we put an electrode around this. Okay, we identify the nerve, put electrode, we put a pulse generator here on the chest, and we intermittently stimulate this nerve. The fibers, 80% of fibers of this nerve go up. They are efferent fibers. They go and stimulate the serotonergic nuclei. So serotonergic nuclei are stimulated. What will release? Serotonin. It is seen to be improving depression. Okay. So vagus nerve, you can remember left side vagus nerve. Left side cervical vagus nerve. Okay. Left side cervical vagus nerve. Okay. So if you are asked which nerve, stimulation of which nerve or which nerve causes the mood to be happy? Vagus. Okay, vagus. Okay, so this was about depression or depressive episodes. Okay. Now let's come to bipolar disorder. Okay. Now, one important point I want you to remember. So in bipolar disorder, what is happening? Patient is having episodes of depression, along with patient may be having episodes of mania. Okay. Patient may be having depression, along with patient is having hypomanic episode. Hypomania. Okay. Now please understand, we are saying it could be any number of depressive episode, at least one. It could be any number of manic episode, but at least one should be there. So patient is having And it can start both ways. Mania is there, then depression, or both ways. Same goes with hypomania. Okay, so let me make a diagram and ask you, let us say this is the threshold for depressive episode. That means if the patient touches this line, that means he is fulfilling the criteria of depression. Okay, the number of symptoms and duration. Let us say this is the threshold for hypomanic episode, and this is the threshold for manic episode, right? Okay, now before this, if someone is having depression with manic symptom, it is bipolar 1 disorder. It is bipolar 1 disorder. Okay. Someone is having depression along with hypomania. This is bipolar. Yes, good. Bipolar 2 disorder. Okay. So there can be bipolar 1, bipolar 2. Right. So let me ask you this. Okay. So write it down. Bipolar 1, bipolar 2, important, you should know bipolar 1, bipolar 2. This term was more used in DSM-5, ICD-11 is also now using these terms, will be using these terms. So it becomes again very important concept. So let us say we had a patient who had an episode of depression. Okay, let me draw it again. And an episode of hypomania. Then again there was an episode of depression. Diagnosis? Diagnosis, bipolar 2 disorder. Very good. This patient developed an episode of mania as well. Now, will the diagnosis remain same or change? It will now change because at least one episode of mania has occurred. So these diagnoses can change. It's not that you made a diagnosis of bipolar 2, patient will always have this. The patient can turn to bipolar 1. So now since a manic episode has developed, it is bipolar 1 now. So diagnosis will change, right? Now, everyone has understood this? So in the question you may get patient is having depression, hypomania and mania. They may tell you this. So don't get confused. What should I now label? If manic episode is there, manic is more severe than hypomania. If mania is reached, it is bipolar 1, right? Now, along with this, so these are two seen in, we call them as bipolar disorder. But also remember, even a single episode of mania, So the meaning is, let us say patient is having an episode of depression. This patient had an episode of hypomania, and again, let us say at least one episode is there. So we will say this is bipolar 2 disorder because depression with hypomania. Later on, this patient now had an episode of mania, full-fledged mania. Now the diagnosis will change to bipolar 1, right? So this is how I am telling you that if patient is there, given in the question, patient is having depression, hypomania, mania, diagnosis will be bipolar disorder. Which type? Since manic episode is also there, it is bipolar 1, right? Now, this one concept I want you to remember, even a single episode of mania, patient has no history of depressive episode, but patient is just come to you with simply manic episode. That also now we consider to be bipolar disorder. Okay, we will call it as bipolar disorder. Why? Okay, why we are saying so? Because, so suppose this is the patient who has come to us, right? Let us say, so patient has come in a manic episode. Now, it is seen that if you take a good history, if you try to take good history, most of the time, these patients who are in mania right now, in the past, they had a depressive episode. They had a depressive episode, but it was less severe, so less that it went unnoticed. Family members didn't notice it. It may have lasted for 3 weeks, 4 weeks. It was very mild. Most of the patient now, when we see that these patient had a past episode of depression. So now we say, whoever is having manic episode for the first time, we also call it as bipolar. Okay, so this is the concept. ICD-10 still used to say that no, we will call it as first episode mania. If we will have 2 episodes, then I will say bipolar disorder. But DSM-5 says no. Call this single episode also as bipolar disorder, and ICD-11 is also agreeing to it now. Okay, so please remember, even 1 episode of mania we can consider as bipolar. Why are we considering bipolar? We're calling it bipolar because it seems to have a tendency to go both ways. So we have to be, for the future, we have to be sure that, okay, patient may develop depressive symptoms, so you should be careful. Okay, and you should, same way, you should prognose the patient also. You should tell the family members, okay, there may be a time when he's feeling sad, you should come to us. Okay, so that is why we are saying, so that we don't miss anything. Okay, so this is bipolar disorder. We have discussed what is depressive episode. We will discuss what is a manic episode and what is a hypomanic episode, right? So let us come to the epidemiology of bipolar disorder. Bipolar disorder is more common in males or females. How many say male? How many say males? Nearly equal. But yes, if you have to choose one, DSM-5 comes to the rescue. 1.1:1. Okay, slightly more in males, right? Now, etiology again, genetic factors are there. Okay, so many factors are there. Genetic factors are there. Again, you will find a positive family history. You may find a positive family history. In fact, you may find a positive family history of mood disorder, any mood disorder. Okay, patient with bipolar may have a history of depression in some relative. Okay, so you may have a positive family history. Genetic factors are also there. Okay. Now, important is the symptoms. Have you written this? Right. So important are the again symptoms. So symptoms again, duration. DSM-5. What is the duration for depression? Depression 2 weeks. Mania 1 week. 1 week or 7 days. 1 week. Okay. 1 week. Even ICD-10 agrees. ICD-10 also agrees. So duration, that means the symptom, whatever symptoms we are going to discuss, they should be present minimum for 1 week. Okay. So let us discuss another mnemonic to remember the symptoms. So the mnemonic is me, don't, sit, always, fly. Okay. So the mnemonic is me, don't, sit, always, fly. Again, the mnemonic is telling us certain things. Person is not sitting, just keep on moving around. He's full of energy. Okay. There the person was not having energy, the patient here is having excessive energy. Okay. So what is M? M is mood. So what is the mood here? It is elated, excessively happy. Elated, excessively happy. Or sometimes the mood can be irritable. Okay, patient is without any reason, is very cheerful. Okay, elated, very happy, excessively happy, cheerful, laughing, singing, as if, just, won a lottery, So, without any reason, patient is cheerful. We don't mind someone to be cheerful. No? It's not that we don't want anyone to be happy, but he's abnormally happy. Okay, and irritable. Okay, some patient may be irritable. They'll become very angry. Family members will say nowadays he's becoming angry on small things. He's chidchide over. So irritable. Then E is energy levels. Energy is significantly increased. Significantly increased. Okay. So the energy is significantly increased. Right? Now, So to make the diagnosis, both these should be present. Both of these should be present, plus 3 or more of the following symptoms which we are going to discuss. So both these should be present. Okay. And the rest symptom which we are going to discuss. D is patient is very distractible. So there is distractibility. So patient will not be able to focus on one task for a long time. He's doing something, he'll leave the task, start doing something else. Leave it, start doing something else. Okay. So patient is, because the energy is so high, the thoughts are moving very fast, he's not able to focus on one task for a long time. So you're talking to the patient, suddenly there is a noise, he'll go there. There is a noise there, he'll go there. So they're very easily distracted. Okay. Then S is sleep. In depression, what was happening to sleep? Patient would come to us and say, doctor, I am not able to sleep, please help me. Or some patient will say, doctor, I am sleeping a lot, please help me. Here the patient will say, who requires sleep? Sleep is for lazy people. I don't need sleep. So there is a decreased need for sleep. We'll say sleeping is a waste of time. I have so much to do. So family members, so we had a patient, 20-year-old male patient, since 10 days symptoms were there. Family members came and said, doctor, since 7 straight days, he's not slept for a single hour. And still see he's moving around, still full of energy. So there is a decreased need for sleep. Okay. So because the energy levels are so high. Then I is inflated self-esteem. Okay, so they would think that they are some very important people. They have significantly high self-esteem. They'll come like a king. They'll sit like this. So depressive patient will sit like this. They will sit like this. Okay, as some king is sitting, and they'll enter and they'll expect that everyone should rise. Okay, so they have an inflated self-esteem. I am a very important person. Okay, and what are they doing? They're talking a lot. Keep on talking and talking and talking. They're just talking a lot. You ask them, please, I've listened to you, stop. No, they'll not stop. Extremely talkative, yes. Extremely talkative. Extremely talkative. Okay. Activity levels will be very high. And these activities may be harmful at times. We had a patient who was brought by the family because he broke 2 glasses of Mercedes, 2 glasses of an Audi car. And father said, I don't know what the hell is he doing. Please, sir, admit him. So police was called there. Police found that something abnormal is there. They put the patient. He was admitted. They may, do a lot of excessive, they will do purchases. Family members will say, doctor, 10 lakh money was there yesterday in the account, now 0. What rubbish things he have ordered, see, useless things. They excessive, purchasing they may do. Sometimes some patients become excessively religious. 10 types of, tabis and 10 types of, malas they are wearing, they become, a lot of tika and all those things, excessively religious. Doctor is, for 2 hours, 3 hours, is doing just this, sitting at home, doing this. And initially patient will become happy, but when they say, it is becoming out of control, so their activity levels increase. They may indulge in any activity. Some activities may be very harmful. Okay. What was something related with flyer we had discussed in mania? Flight of ideas. Right. Flight of ideas. Okay. So flight of ideas we discussed. Patient is, the thoughts are racing very fast. So things are connected by chance so we discussed that, right? So this is how we make the diagnosis of mania. A patient, 20-year-old male patient, 10 days history with symptoms of excessive cheerfulness, increased energy, decreased sleep, talking a lot, not going to work, causing a lot of chaos at home. Family is not able to handle. Diagnosis, manic episode, right? Okay. Everyone understood this? Yes. First two symptoms should be there. Along with this, so these 2 symptoms should be there. Along with this, 3 or more of these symptoms. Okay, so then we say it mania. Again, don't start counting in the paper. If you feel that okay, they're talking about mania, it is mania. Okay. Again, it's an episodic illness. If you don't treat, patient will improve, but it will take 4 to 6 months. Okay, sometimes these patients also develop, remember, we discussed, patient can also develop psychotic symptoms like delusions or hallucination. I am the king, I know everything. Sometimes other delusions can also be there. Persecution can also be there at times. People are talking about me because I have a lot of money. So there can be other things also. Okay, don't think only grandiosity will be there. Okay, so you will add the specifier. This will help in the management. I will discuss about the management. Okay, now what is hypomania? It is similar to mania. First of all, you should know the duration. Hypomania, duration of depression. Mania, 7 days, 1 week. Very good. For hypomania, 4 days, even less. 4 days. I'm talking about minimum duration. It's not that if symptoms for 1 day, we will not call it as hypomania. If at least for 4 days. Sometimes you win a lottery for 1 or 2 days, you may be in that hypomanic state, but then you will come to your senses, right? So it is similar to mania. Okay, but it is not severe enough, or you can write it down. So it's not severe enough. Severity is low, not severe enough. So we say, now tell me what will happen to the functioning of a patient with mania. Significantly deteriorated. He'll go to his office, the office will people say, please go home. No, he's just doing things and not completing things, disturbing others, so they'll not be able to handle things, distractible they are. Okay. But in hypomania, we say the functioning is not severely deteriorated, but functioning is very less affected. So functioning may be normal. So these patients, they have excessive, cheerful they are. Okay, so they will start doing work even sometimes more efficiently. So for some days the patient will, feel that, it's a very good thing which I am having hypomania. But of course, later on they will have problems. Okay, so sometimes patient come to us, a bipolar 2 patient come to us and say, doctor, please keep me in that hypomanic phase. I'm very happy that time. Okay, but we know that's an abnormal state. Okay, now. So that is the difference. One more thing, a hypomanic patient will never have, will never have psychotic symptoms. If psychotic symptoms have developed, then you have to call it as mania with psychotic symptoms. Okay, psychotic symptoms you will never say it is hypomania, right? So symptoms are similar, we have discussed, just that their intensity. So in the question, how will you differentiate? They will say patient is doing things better now, or patient is efficiently doing things, or is impaired, functioning is not impaired. That is probably they're talking about hypomania. So when they talk about hypomania, this is what they will give. Okay. So everyone has understood. We know what is depression. We know what is mania, what is hypomania. Now we also know what is bipolar disorder. 1, 2, we know all those. Okay, how to diagnose, right? Let's come to the treatment. Again, treatment is very, very important. So BPAD is bipolar affective disorder, or simply bipolar disorder you can write, right? Okay, last slide. Just see if you missed anything again. I'll show both the slides, mania and hypomania. Okay. Now, treatment. Now, of course, when we are managing treatment, managing the patient, we are either treating the manic phase or we are treating the depressive phase, isn't it? Either patient comes to you in mania or hypomania, or patient comes to you in depression. So let's see what will we do when the patient comes to us in acute mania or hypomania. Okay. Now let me give you a scenario. Let us say this patient who has come to us. So this patient has come to us. So there is a history of a 20-year-old, 30-year-old male patient with symptoms of excessive cheerfulness, excessive talkativeness, decreased sleep, distractible, increased energy. Okay, since 20 days. Okay, so this is the patient who has come to us. What is the diagnosis? Mania. Right. Okay, and we have to treat this patient. What if I say that 1 year back there is a history of sadness? 1 year back there is a history of sadness, decreased interest, decreased mood, decreased energy, decreased, which lasted for 6 months. Okay, so we know that there is a history of depression, right? Patient was started on antidepressants. Okay, patient was started on antidepressant and now patient is in mania. This is the clinical scenario, right? And you are asked to treat this phase. Everyone understood what we are talking about? It could be mania or let us say hypomania. Agreed? So now we are talking about management. Okay, if such a question comes, and please understand, very high chances this question will come. Very high chances. So they will ask you, what will you be your step 1? What will you do? What will you do? You will stop the antidepressant. Don't think of starting anything first, because antidepressant, what does it do? It elevates the mood. Patient mood is already so much elevated. You need to stop that. So this point is very, very important. Stop antidepressant. If in the question you get to know that there is, suppose they have not mentioned in the question, they have just said patient is having manic episode, history of depression. They have not said that patient is on antidepressant. But in the option they give you, stop antidepressant as one of the options. That means they are trying to check whether you know this concept or not. So you will stop antidepressants. This is the first point. Everyone understood this? Very important, put a hashtag. Then they will ask you management. Now please understand, as per the current guidelines, there is no one drug. There is no one drug which I will say it is drug of choice. For depression, I said SSRI drug of choice. No one single SSRI I have mentioned. Remember, I told you SSRI. I didn't say fluoxetine, sertraline, paroxetine, any. Okay, but here we don't say one drug to be. In your books, guidebooks, you will find they have mentioned one drug of choice or this drug of choice. No. According to patient profile, you can choose, but there is no one single. There are 3 drugs which are used as first line drugs. You should know them. Antipsychotics. So make a table like I am making. We'll discuss some important points. Lithium, valproate. Okay. Antipsychotics, lithium, valproate. Okay. Lithium and valproate are mood stabilizer. In fact, there were 3 questions. There were 3 questions from this topic. This point we always discuss when we are discussing this point, and this question was in fact asked as well this time in the exam 2020. So June 2021, 3 questions from this topic which we are discussing. 3 questions. Okay, so please understand this happens in psychiatry. They choose one topic and they ask many questions. They are asking many questions from child psychiatry, 2 to 3 questions each time if they are asking child psychiatry. Alcohol, so they are asking every time they ask alcohol. Okay, and mood disorder, they have asked 3 questions this time from this topic. Okay, so I'll discuss that question again. So lithium and valproate, I told you these are mood stabilizers. So just like you put a stabilizer, voltage stabilizer at home so that the fluctuation in voltage is controlled. Similarly, the mood fluctuation we are stabilizing by a mood stabilizer, right? So antipsychotics like olanzapine. Okay, like I am just mentioning some, haloperidol. Okay, risperidone. There is one qutipin. Okay, aripiprazole is so many. Qutipin is again a second generation antipsychotic. It's again a second generation 2G. So nowadays we have 5G network, but still antipsychotic we have 1G and 2G. Okay. Typing. Okay. So in which profile you may be asked this question has been asked before. In which profile you may have, sometimes you have to choose one. So that does not mean that there is a drug of choice. That means that, depending on the situation, you will choose the drug. Suppose patient has a lot of severe symptoms. So symptoms are very severe. Patient is having severe symptoms. Or suppose patient has developed psychotic symptoms. Then using antipsychotics makes sense, which will control both. So if the patient has developed psychotic symptoms, right? So in those conditions you may choose, right? Now, valproate, few points about valproate. You'll discuss in pharma also. Valproate is a very important drug. Lithium valproate, both are important drugs. You should avoid in female in reproductive age group. Okay. You should avoid in reproductive age group. Can anybody tell me what happens if a female in reproductive age group takes valproate? Yes, in ovary you may get PCOS or PCOS, polycystic ovarian syndrome or polycystic ovarian disease. So I'm saying avoid it. I'm not saying it is not used. It cannot be used. I'm saying avoid. If possible, avoid it. Okay. Right? Suppose a patient is pregnant. Suppose patient is pregnant and you have to choose a medicine. Patient is pregnant, developed mania, hypomania, you have to start some drug. Which drug will you use? If possible, antipsychotic. If antipsychotic is not there in the option, go with lithium. If lithium is not in the option, don't use valproate. Valproate, no. A no to valproate. Why? Now, can anybody tell me, so what are teratogenic effect? Teratogenic effect. So these are basically malformations which occur in the fetus when mother is consuming some drugs. Okay. There are so many teratogenic effects you must have read in your pharma. You read. Lithium also causes a teratogenic effect. Can anybody tell me? Very good. Epstein anomaly. Epstein anomaly. It's a which system is affected in Epstein anomaly? Cardiovascular system. It's a cardiac anomaly. Question in June 2021. Such a simple direct question. Direct question. They just gave a clinical scenario. Patient is pregnant. She is on lithium, and they've given clinical. The question was, what is the effect? Okay, Epstein anomaly. Very, very important. Valproate also causes some so it causes, yes, neural tube defect. It affects the CNS. Now, even though lithium causes Epstein anomaly, teratogenic effect, still we use. First of all, we should know that the incidence is very low as compared to neural tube defect by valproate. Incidence is very low. Second of all, it is surgically, it can be repaired. Surgically, it can be treated. Okay, so lithium still we can use. Of course, if you have to use antipsychotics, will be a preferable drug. No teratogenic effects have been identified up till now with antipsychotics. Okay. Now, there was a question, a 30-year-old female, a 30-year-old female having manic symptoms what drug you should use. Okay, and in that one of the option was lithium, one of the option was valproate. We'll prefer lithium, although we can use both, but this is how you have to see in the question. Okay, sometimes what we have to do, sometimes we have to add antipsychotic. If patient is not improving, we have to add lithium or valproate. Sometimes we can add lithium and valproate. So this we can do. This combination permutations we can use. Okay, if severity is more, one drug is not helping, we can add other drugs. And along with this, along with these drugs for short duration, we also add benzodiazepines. Okay, so we also add we add antipsychotic, lithium, valproate. Along with this, initially we also add certain benzodiazepines to calm the patient, sedate the patient. Okay, benzodiazepines should be used for long term or not? No. Why? They are addictive. Abuse potential is there. So many times, some physicians started a benzodiazepine. Patient comes to us and says, doctor, since 5 years I am taking on my own. In India, you get medicines without prescription at times. It doesn't happen in the West. Okay, so people become addictive to benzodiazepines. Okay, so benzodiazepine we can give it for a few days or few weeks, then we stop. Okay, so this was acute mania or hypomania. Again, many questions can be framed from this small treatment plan. And they are asking questions. Second is acute depression or bipolar depression. Now, so this depressive episode is different from a episode in simply unipolar depression. Okay, this is bipolar depression. Everyone understands the difference? Everyone understands the difference between unipolar depression and bipolar depression. What was the treatment of choice in unipolar depression? SSRI, that is antidepressants. Here, please understand this concept. Never give antidepressants alone. Never give antidepressants alone. Okay. Why so? See, yes, patient has a tendency to go to the upper pole. Patient started with antidepressant, 2 weeks later, family was bring, doctor, now he's in mania, what I do? Depression we were able to manage, mania so we cannot manage. Family will come. Okay, so never use I'm not saying antidepressants are not used. They are used along with certain mood stabilizer. Okay, so the first line of drug, which is, so this combination has been very effective, it is seen. So the first line of drug for acute depression or bipolar depression is a combination of fluoxetine, and olanzapine. This combination has shown to have a very good response. Okay. Fluoxetine is an SSRI, right? And olanzapine is an antipsychotic, which is useful for. So it works like it works like preventing a manic or a hypomanic episode. Okay. So sometimes, other drugs can also be used, like we can use lithium. Singly, we can use lithium. There is one mood stabilizer, lamotrigine, very good, which is, lithium is used also in mania, but this lamotrigine is only used for depressive phase. It does not show much improvement in manic phase. So it's also a mood stabilizer. Okay. Sometimes drugs like Qutipin can also be used. Okay. So if you have to, you say that, the patient is having a lot of trouble, the patient is having a lot of symptoms, I need to start an antidepressant. We say, okay, we can start an antidepressant. Okay. We can start an antidepressant, but we along with this also have to start MS is a mood stabilizer. So any mood stabilizer you can also add. So you can start SSRI plus a mood stabilizer. This will prevent the chances of a switch. Okay. So again, this is an important concept. So they may simply ask you, patient is in depression, there is history of mania. Diagnosis is bipolar depression. When they ask you treatment, they will first option they will give you SSRI. Last option they will give you SSRI plus mood stabilizer. So always read all the options carefully. Okay, simple questions will come. Right? Everyone has written this? Okay. Now, next is, so sometimes patient says, doctor, I am having these episodes recurrently. 2 episode, 3 episode, 4 episode. Can you give me any medicine which will decrease my risk for future episodes? So we say yes. If patient has 2 or more episodes, we can, so prophylactic management, just like in migraine we do prophylaxis. Similarly, we can do prophylactic management. Okay, so we can give lithium or valproate. Okay, we can keep the patient on lithium and valproate. Okay, for prophylaxis or maintenance therapy. Okay. Yes, sometimes, yes, sometimes, but even in your CNS, seizures, you must have, because valproate is what? It's an anti-epileptic, isn't it? So sometimes, if patient is showing good improvement, sometimes we may have to continue medicine. Okay, so this you have to see pros and cons, you have to see. But if you get a chance, then consider antipsychotics, lithium, then valproate would be the last option. Okay. Because let us say if the mother's symptoms are not controlled, pregnancy outcome may also be very poor. So this was about bipolar disorder. Next is another small topic, persistent mood disorders. Okay, persistent mood disorder. From the name itself, we are getting that's, I told you, yes, above ones were episodic illnesses. They would occur for a few months, right? Naturally also. But there are certain disorders which may persist for some time. So they persist for a longer time. So this is persistent mood disorder. This one is very important. 2 to 3 questions have been asked from this topic in the last 3-4 years. Dysthymia. Dysthymia. So what is dysthymia? Let us write it down. Patient has mild depressive symptoms. Please understand this. I am not saying patient has mild depression. To call it as depression, one of the 2 plus 4 or more symptoms, that criteria was required for 2 or more weeks. I am saying patient is having mild depressive symptom. For example, patient is just having low mood, just having decreased interest, just having decreased energy. So mild depressive symptom which is not fulfilling the criteria of a depressive episode. Patient's functioning more or less is normal. Okay, so patient says, doctor, I am able to do the work, I am able to do office, I am able to do, I have to push myself, but I am able to do. And this is occurring for at least 2 years. This is dysthymia. So if we have to make the graph, so let us say this is the threshold for depression. This is 2 years duration. Okay. Right? So what is happening? So patient says, doctor, there are days in the past 2 years, there are days when I am feeling low. I am feeling sad at times. Sometimes I feel decreased energy. Sometimes there is decrease in the sleep. And these symptoms are continuously present since 2 years. These symptoms, you can see in these 2 years, never it had happened that yes, that's the line for depressive episode. So symptoms are very mild, but they are continuously present. Never during these 2 years he was normal. Okay, so these symptoms have been present continuously. But patient says, doctor, I'm able to do my work, everything, but now, doctor, it's been 2 years. Please help me. This is dysthymia. So dysthymia, when they will give you mild symptoms. They will tell you it's for 2 years or more. They will tell you the functioning is normal. He's able to do. So they will give you some catch lines. You have to see. about the functioning. They'll say it is more or less maintained. He's able to do. He's going. Okay. So this is dysthymia for him. Okay. Now, yeah. No, it's not normal. It's a disorder. It's a persistent mood. Whenever disorder terms comes, it is not normal. Common. It's common. It is seen. Yes, it is seen. Right. Now, few things you need to know. DSM-5 uses a new term for dysthymia. Persistent depressive disorder. So name is telling you it's a depressive disorder which is persistent. Okay, so this question has been asked in 2018. Persistent depressive disorder is option, one of the option was dysthymia. This has been asked in your FMG exam. Okay, sometimes what happens after a dysthymic episode or after dysthymia, patient ultimately may develop a depressive episode. Okay, so ultimately patient lands into a depressive episode. What is this known as? This is double depression. This question again has been asked 2017. Back to back they had asked these two questions from this topic. Now we can expect, since it's a very interesting topic, to make the diagnosis, they may ask you as the clinical question. They give you symptoms and they'll ask you. Okay, what is double depression? It is dysthymia. So there is a dysthymic episode. It is dysthymia followed by a depressive episode or depression. Okay, so both these have been asked in your MCQs. Please remember. So just again a small topic, but they have asked question. You can expect a question of clinical question from this topic. Again, management. Yes, we can use CBT. We can try CBT. Of course, we can also use antidepressants. Please choose according to the patient profile. Okay. Okay. So again, this is a very important slide. Right? Shall we move forward? Right. Okay. We'll wait. Any doubt in this time, please ask me if you have any doubt. Because you can expect a question 3, you can understand 3 questions from this single topic. Okay, so so these are very, very important ones. Next is cyclothymia. Next is cyclothymia. You can consider it a milder form of, it's a cyclothymia. Treatment, I told you, you can use therapy. Treatment, you can use therapy like CBT. You can also use antidepressants. Okay. Okay. So again, cyclo means cycle. So now the symptoms are cycling up and down. Okay. So it's a milder form of bipolar disorder. It's a milder form of bipolar disorder. Okay. Again, here I am saying it is form type. I am not saying it's a bipolar disorder. Okay. Functioning again is normal. It is also a persistent mood disorder. So duration. Symptoms are present for, what was duration for dysthymia? 2 years. So at least 2 years. Okay. So let us make a graph again and try to understand. Let us say this is threshold for depression. This is for hypomania. This is for mania. Okay. And this is 2 years duration. Okay. So patient will say, doctor, there are days when I am feeling sad. Sometimes I feel more cheerful than normal. Then sometimes I feel sad, decrease interest. Sometimes again the energy levels go up more than normal. And this has been continuously present. So So you can see never ever during these 2 years patient has touched the threshold for depression. Never ever they have touched a threshold to make a diagnosis of hypomania. So it's just fluctuating between, happy mood and low mood. So he's cycling between these two. This is cyclothymia for him, right? This is cyclothymia. Not half, but just fluctuating. Maybe majority is having depressive symptom, but then he's also having. So I cannot call it as dysthymia, isn't it? So it can be. It's not half. It can be any percentage of both these. But he's fluctuating. Okay, he's cycling between the two. Okay. Be careful. Such patient have a risk, just like those double depression. Such patient have a risk going into full blown bipolar disorder. Okay. Again, in the management, we can use medicines. We can use drugs. Again, it will depend. The medicines will depend on the profile of the patient. Again, you can choose a mood stabilizer like lithium because it will help in the maintenance also. Or you can sometimes use antipsychotic depending upon the symptoms. Okay. If depressive phase is more there, then you may also choose to have antidepressant. Okay, but just understand how to make the diagnosis. That is more important. Okay, right? So everyone has written this. Okay. Now, one important point about bipolar disorder is, again, this has been asked. A very beautiful question was framed in 2020. A very nice and a very good question was framed in 2020 exam. June 2020 exam on this very small topic. Yeah. Okay. Okay. So rapid cycling. It's basically rapid cycling is in bipolar disorder. So what is rapid cycling? The name is telling you symptoms are cycling up and down. Rapid means very frequently. So there are 4 or more episodes of depression, mania, and hypomania. Okay, 4 or more episode can be 2 episode depression, 2 mania, can be 1 depression, 3 mania, 3 hypomania, 1 depression, any number, any permutation combination. Okay. In very, very important. Again, we discussed this always. They in fact framed the question over it, and it was a clinical question. Earlier, they would ask patient having 4 or more episode of this in 1 year diagnosis, rapid cycling. Now they gave a clinical scenario. Okay, what the question was that there is a 30-year-old female. Okay, 30-year-old female. She had 6 episodes. She had 6 episodes of depression, mania, and hypomania in 1 year with full recovery in between the episodes. So what this is telling you, that in between the episodes she would that means it is episodic illness, isn't it? Because in the one option was cyclothymia. They are saying she has 6 episodes in 1 year. She had 6 episodes, and in between the episodes she was all well. That means these are episodic illnesses. Diagnosis, the option was rapid cycling bipolar disorder. That was the correct answer. Okay, so this was a very recent question. Just a simple topic, and they asked, framed a very good clinical question. They're asking such question. That is why we're discussing this. If I just tell you and we don't discuss it clinically, then we may not be able to make the diagnosis, right? Now, they may go one step further and they may ask you, okay, tell me the treatment. Okay. For rapid cycling, it is seen that valproate is found to be very effective drug. Valproate is found to be very effective drug. So again, you are getting a patient who is having acute mania, but you see in the past that patient has more episodes, 4 or more episodes, then you can choose valproate. Okay, so you have to choose, again I am saying there is no one drug. So everyone understood this concept. So this is very important. Questions have been asked. Then, of course, you can choose antipsychotic, you can choose lithium. But if the situation permits, then valproate. Okay. Lithium generally does not show much effect in this. So that is why valproate. Otherwise, you can use antipsychotics. Okay. Now, last topic here is again very important topic. suicide. Okay. Again, many questions have been asked from this topic. Suicide. What is the rate of suicide in India? It is 10.4. 10.4 per 1 lakh population. So in 1 lakh population, 10.4 people commit suicide. Okay, so more than 10, right? Which is the most common mode or method of suicide in India? Very good. It is hanging more than poisoning. Okay. 40 to 45% are hanging and roughly 20% poisoning. So hanging is more common. Right? Psychiatric, again, this we have already discussed. Psychiatric disorder with highest risk of suicide, very good. Depression. Again, other disorders like bipolar disorder, schizophrenia, substance use, all those have a higher risk than general population, but highest is with depressive episode, right? Okay. Everyone's written this?
Yes, sir.
Okay. 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 Now, next important point is the risk factors. Now, this also you can expect a clinical question. Earlier, they would ask you, yeah, highest is depression. We have, yeah. Okay. Psychiatric disorder with highest risk of suicide is depression. Now, risk factor for suicide. Yes. Okay. Okay. Don't worry if you missed anything. We'll discuss in the end again. Okay. So you can get a clinical question. A 30-year-old female. These are the factors. She's having this. Which of the following is the risk? Which is the factor which you will suspect that risk of suicide is high. Okay. So they may ask you as a clinical question. Again, very important. So, which is the most important risk factor? That means if this is present in the patient, you have to be very careful. A patient comes to you, says, "Doctor, I am having suicidal thoughts." Okay. But if this risk factor is present, you have to be very, very careful. Don't leave this patient untreated or unhandled. You have to handle the patient. You have to treat the patient. What is that risk factor? Very good. Very good. Previous suicide attempt. So a 30-year-old female patient, who has a history of a suicide attempt, very important risk factor. Very high chances patient has attempted before, can attempt even now. Okay. Second, if you ask me what is the second, if you ask the patient what will you do tomorrow, what are you planning to do tomorrow? Doctor, tomorrow, who has seen tomorrow? Kal kisne dekha? It is very dark, very bleak. I don't know. I don't know what I will do tomorrow. So what is this? This is hopelessness. Hopelessness. That is negative views of the future. Never ever shy away from talking about suicide from a patient with depression. Don't feel that if you ask, what if the patient do? No. You should always ask. So a patient with depression comes, you always ask. Does any other thought come to your mind? Or does it come, thoughts of harming yourself? So you should ask. Patient tell you. Patient will tell you. Okay. So if the patient has hopelessness, I think future is nowhere. Be very careful. Patient, discharging a patient, what will you do tomorrow, sir? I'll go watch the cricket match. Okay, go. You're discharged. Okay. So he's not hopeless, at least. He has some good plans. Okay. So these are some important risk factors. Then other factors are, tell me, So the other factors are, tell me, male gender is a higher risk factor or female gender is a highest risk factor? How many of you say male? How many of you say female? Okay. Okay. So generally females are more successful in other areas, but here males are more successful. So males. Right? Yeah. So why male is a higher risk factor, although I told you that depression is more common in females? Lethal methods. Females, what may do? They may poison. Okay, you take to the hospital, they are safe. Males, direct jump. So more lethal methods. Okay, because of more lethal methods. Age more than 45 years. So age more than 45 years. Again, someone who is married is at a higher risk or unmarried is at a higher risk? Okay. Yes, someone who is unmarried. Patient says, doctor, I got a thought that I should end my life, but suddenly the picture of my family members, my children came in front of my eyes. I stopped myself. So many times we say, keep a picture of your family in your wallet. Okay. So someone who is married has a social support. Okay. Yes, sometimes marriage becomes a factor for suicide at times, but that is a different thing. But overall. Okay. Then someone having chronic illness. Sir, I'm having pain since 10 years. I'm not able to bear it anymore. I'm having tumor. There is no treatment. So chronic illness again can be a risk factor. Then substance use. So patient in intoxicated state committed suicide. Substance use can also lead to, again, psychosis can also lead, we have discussed, that other disorder, psychosis. Family history of suicide. Again, it's a higher risk factor, someone in the family committed suicide. Okay. History of abuse, sexual abuse or physical abuse. History of abuse can also lead to, is a higher risk. So there are many factors. But I've also told you the most important ones. So 30-year-old female, she is having depression. She has started drinking alcohol. She recently got divorced. There is a history of consuming a lot of pills. Okay, which of the following is the highest risk factor? 1. There is history of consuming excessive pills. Since suicide attempt, so previous suicide attempt. Okay, so this is how they may frame a question. Okay. Now, last point around is, what is paradoxical suicide? So what is paradoxical suicide is, so there is a paradox. That means something which should not occur is occurring. Paradox means this, something which you are not expecting is occurring. So what is paradoxical suicide? In the initial stage of treatment or recovery, a patient is having depression, suicidal thoughts. Okay, severe depression, suicidal thoughts. In the initial stage of recovery, attempt suicide. So what is happening? Patient was having severe depression. Patient was having suicidal thoughts. Patient never attempted suicide. You start treatment, within few days, patient attempted suicide. That is the paradox. We are treating, but she attempted suicide. Why? Because yes. Because earlier patient would say, doctor, I am feeling very sad. I don't even have the energy to commit suicide. But you started treatment, suicidal thoughts are still there. Patient gains energy and ultimately now attempts. So because of gain of energy. So initially you have to be careful. It's not that, okay, I have started the treatment, now I don't have to follow. You have to follow, be careful. Tell the family members also. Okay. Last point, again put a hashtag. This can be an expected new question. What is paradoxical suicide? There was one question previously asked. So there was one question which was asked, what is copycat suicide? What is copycats? You know, in the school days, you would say someone copying your notes, you say he's a copycat.
My friends find it file.
Yeah. So not that, but mimicking, yes, mimicking the method of suicide by other person. Right? That is copycat suicide. So through the local newspaper, local media, there is, you know, someone committed suicide, people get to know about it, and then they also attempt suicide in the same manner. The question which was asked was in which population it is more common. Now there again is controversy. Some books have given some answers. Now the answer will vary according to the option. If the question which was asked, it may be that the option was child, young, you know, child was there, adult, elderly, or none of the above, then you can go for child. But a better answer will be adolescent. I'm not saying they have the wrong answer or not, but if you have both the option, adolescent and children, go for adolescent. Okay. So more in adolescent population, right? So this was your previous year too. This was a question in, I think, 2019 they had asked, or 18 they had asked this question. So they had asked copycat, paradoxical, they have asked in some other exam. So I recently they had asked this in some other exam. High chances such questions can come, right? Okay. So this was about suicide, again a very small topic, but you can expect some questions from this. Okay. So always carry that attitude, you know, I'll make it. Okay, and you'll do it. Okay, so let's take a break. Let's Let's start. Today we'll start. Finish at 3:30 today. So we'll take a lunch break later on. So it's 12:35. Let's meet at 12:50 again. 15 minutes. Let's take a 15 minutes. Hey, lunch break. Nee. I'll give you a lunch break. Okay. I'll give you a lunch break. 12:50. We will take lunch break. We'll start again at 12:50. 3:30. I think some online is there now, so we'll discuss. Any doubt if someone has, let me know.
सर अब यूथनेशिया लीगल है या नहीं? इंडिया में यूथनेशिया लीगल नहीं।
Sir, in depressive condition. So we are going to discuss now anxiety disorders. Anxiety disorders are neurotic disorders. These are neurotic disorders. So, you know, anxiety disorders we are going to start. I'll just wait for another minute. Let's let everyone come and then we'll start. Okay. So basically, just like in mood disorder, problem was in mood. So in anxiety disorder, the problem is of anxiety. All of us have experienced anxiety. Okay. There is an interview tomorrow, you are anxious. There is an exam tomorrow, there is anxiousness. Okay. So all of us know it's a vague, unpleasant feeling. Anxiety is a vague, unpleasant feeling with symptoms like sweating, palpitation, tremors, all those things. So normally also we have experienced anxiety. But if this anxiety becomes abnormal, then we call it as anxiety disorder. Okay. So let us discuss all these anxiety disorders have been asked previously. Please remember this. The anxiety disorders have been asked. Okay. So the first anxiety disorder which we are going to discuss is panic disorder. Okay. So we are starting with anxiety. Okay. panic disorder? Question has been asked. A very important, very interesting phenomenon. So before starting panic disorder, let us understand what's a panic attack. Okay. So what's a panic attack? It is basically a sudden, intense, onset of anxiety. Okay. So there is a sudden, intense onset of anxiety, suddenly and very severe. So please understand this. So what is happening in a panic attack? There is a sudden, intense onset of anxiety. So what all symptoms will be there? Patient will complain of palpitation, sweating. Okay. Patient may complain of chills. Patient may complain of abdominal discomfort. Patient may complain of tremors. So all of us know what is anxiety, isn't it? As we're discussing, all of us have experienced anxiety. Okay. So what is happening in panic? So we are discussing panic disorder. And in panic disorder, first let us understand what's a panic attack. Panic attack is a sudden, intense onset of anxiety. So in anxiety, you can have, all in other symptoms are also there. Nausea, vomiting, those symptoms may be there. Okay. So patient has suddenly the anxiety has occurred and is very severe. Okay. With these symptoms, along with these symptoms, one very important symptom you need to remember is there is a feeling of, very good, there is a feeling of impending doom. Feeling or fear of impending doom or fear of dying. Fear of dying. Okay. So patient says, doctor, I'm sitting at my home. I'm sitting in my office. Suddenly, out of nowhere, there is a sudden onset of very severe anxiety. I'm having palpitation. I'm having breathlessness. I'm having vomiting sensation. I'm having tremors. Suddenly, without any reason. And doctor, I'm feeling that I'm having chest pain. There may be chest pain. Okay, so these symptoms may be there. So doctor, I feel, I am about to die. Doom is everything is going to end. Impending means it is just about to occur. So there is a, everything is going to end. This kind of feeling. Oh my God, I am having a heart attack. Take me to the hospital. Such severe, intense anxiety. Okay. And this lasts for some few minutes. This lasts for few minutes. Or sometimes may go on for few hours. Okay, so it will be within few minutes, patient will become all well. Okay, so there is no physical cause of these symptoms. Okay, so anxiety will suddenly happen. Patient will have this fear of him dying or fear. This, please remember this point. If you have this in the patient, they are talking about panic attack. Please remember this. This question has been asked previously. Okay. So along with other symptom of anxiety, there is a fear of dying, feeling of impending doom. Right? So very important. And this lasts for few minutes. It's not long lasting. Patient becomes all well. Okay. So what is panic disorder then? Recurrent panic attacks. Recurrent panic attacks is panic disorder. Okay. So patient is having recurrently these attacks. I'm sitting at my home, suddenly there is an attack. Few minutes later, patient is all well. Okay. So initially, when first time this attack occurs, generally most of the patient rush to the hospital because they feel, oh, I'm having a MI, myocardial infarction. I'm having some serious problem. They visit the hospital, they are examined, investigated, everything's come out to be normal. And then the symptom, you give some medicine, the symptoms go up. No, so generally these patients, when they come to psychiatry, you will have all these investigation, everything. The diagnosis is there on your table. Okay, otherwise you would want to rule out other things, but they would come with all these investigations, because initially they will think it might be some physical cause. Okay, but there is no. There is only psychiatric problem. Okay, so please understand this. These attacks occur unexpected. That means they are not restricted to any situation. They are not restricted to any situation. That means it's not that they will occur only in one particular situation. So patient will say, doctor, one episode occurred when I was at my office. One episode occurred when I was at my home. One episode occurred while I was watching movie in a cinema. So how are these patients present? So these patients present like this. Sudden onset of anxiety. Initially the anxiety is very severe, suddenly. And within few minutes it will go out. Again, so patient become all well. Again, let us say after few days, few months, again there is one episode. Again he will become all right. Again, so such history if you get, it is panic disorder. You can see in between patient is normal. Okay. So please remember this. This has been asked multiple times. They may ask you again, what's a panic disorder? Okay, they may ask you the diagnosis. Now, of course, when such patient comes to us, initially we have to rule out. I will not say, oh, you are having anxiety and you are having chest pain. No, don't worry, this is panic disorder. Few minutes later, patient succumbs. He had actually had a MI. So we have to rule out initially any physical cause, because there are many physical disorders, medical illnesses which will have similar complaints. So you always look for any DD. Look for any, so try to investigate the patient, examine the patient if there is any physical cause. Okay, because of physical symptoms, it must be differentiated from certain physical disorders like cardiovascular, like MI, myocardial infarction, heart attack. Sometimes even a patient of bronchial asthma can also, in asthma also patient will say, I'm not able to breathe, isn't it? Sometimes problems like pheochromocytoma. Pulmonary embolism. Okay, pulmonary embolism. So there are multiple. You'll find a list of these conditions. So any physical condition, many physical, even hypothyroidism, they can have such episodes. Okay, so you have to rule out. You should rule out. Don't be in a hurry. Rule out these physical illnesses. If you say, okay, there is no other cause, and patient then improves within few minutes, then it is more suggestive of a panic disorder, right? Okay. So first is we need to make the diagnosis. First of all, we have to make the diagnosis. Then we also have to treat. Again, in treatment we can use psychotherapy or pharmacotherapy. Drugs we can use. Again, the drug of choice are SSRI. So these are, we call them antidepressants, but they also have anti-anxiolytic properties also. Okay. So SSRIs, along with this plus minus, we can also add benzodiazepine. If someone asks you, patient has a panic attack, currently is having a panic attack, what will you do? What medicine will you give for that particular attack? Please remember, SSRIs will take time. Yes, so benzodiazepine for the acute attack. For acute phase, you can give benzodiazepines. So you give one benzodiazepine, within few minutes patient will become all well. In fact, even when we prescribe the medicine, we tell the patient that if you develop any attack, you can take these medicine SOS. But of course, benzodiazepine we will not continue for a long time because of their addictive potential. Okay, so SSRI. So now I hope you understand if a patient with panic disorder comes to you and in the question it comes, and if they're asking about the treatment of choice or the drug of choice, SSRI, but if they're particularly especially asking for the acute phase, at that time what you will do, you will give benzodiazepine, right? In psychotherapy, we can also use psychotherapy. The therapy which is used is CBT. Okay. Yeah. Yeah. Sometimes you may get, but generally commonly we say panic disorder has no aggravating factor. Yeah, that's what I'm saying. Sometimes they occur, but classically a panic disorder or a panic attacks will be unexpected. Because if it is only occurring in stressful situation, it may be that you decrease the stress, patient's symptoms will go away. So then it may not be, it may look like a panic disorder, but it is not ultimately a panic disorder. Okay. Now, if I ask you treatment of choice, this question was once asked. I've told you drug of choice, I've told you therapy of choice. I'm asking you treatment of choice. Which will you prefer? The treatment of choice. Benzodiazepine was for acute phase. Treatment of choice. Is it drugs or is it therapy? In fact, yes, it is both. A combination. A combination. So you can use drugs plus therapy. So treatment of choice. So in fact, it is good if we start both. Combination has shown to have better results. So suppose they have given you a clinical scenario, you have asked the treatment. One option is SSRI, second option is SSRI plus benzodiazepine, third is CBT, fourth is all. It is all. You can, if you use both together, effects are even better. So that is why we say it is the treatment of choice. This has been asked previously. Okay. So this was panic disorder, a very small topic, but has been asked, frequently has been asked, panic disorder. Okay. Can there be? Yeah, there can be. But if it is because of some other physical condition, then you have to, you have to treat that condition, right? Now, next is agoraphobia. Agoraphobia. Next is agoraphobia. Now, leave some space after agoraphobia. We'll write something there. Let us first, see the criteria. So basically, agoraphobia, panic disorder was situational or not situational? It was not situational. It could occur in any situation. But in agoraphobia, the anxiety is occurring in particular situations. Let us first understand them. This question was asked in 2019, December. There was a lot of controversy. I'll tell you what is the controversy and I'll also tell you what is the right answer. The question was asked and many guidebooks have given the answer as agoraphobia. But in that case, agoraphobia was not the right answer. I'll tell you why. Okay. So first let us know what is agoraphobia. Marked anxiety. So anxiety is occurring severely in, this is important, 2 or more of the following situations. So I'm going to discuss certain situations. So anxiety is occurring in at least 2 or more of these situations. Let us understand what are the situations. So patient says, doctor, when I'm using a public transport, for example, I'm using bus, train, metro, I get severe anxiety. So much so that I have to get out of it. Doctor, since 3 years, I've never used the public transport now. So in public transport, I get this anxiety. So this is the first. Okay. Then, doctor, when I'm in very open spaces, like I'm in big parks, or I'm in big parking areas, I'm in big malls, I get anxiety. So much so that I am started to avoid those situations. Okay. Second is in open spaces. Right? Third is in closed spaces. So doctor, when I am in lift, I get anxiety. I am in a cinema hall where doors are closed, I get anxiety. Okay, so doctor, if I have to go 10 floors, I always use stair. I cannot use lift. Okay. Then next is when doctor I am in a crowded place, or when I am standing in a line, again I get anxiety. I cannot go to places where there is a lot of crowd. Okay, I cannot stand in a line for a long time. Or if I go alone outside of my house, again I get anxiety. I cannot go alone. I always have to take someone. So this is not normal anxiety, isn't it? So please remember this, it has to be 2 or more situations. The question which was asked in your exam was, a patient is having anxiety in using lift and he avoids lift now. And they had asked diagnosis. So one of the options was agoraphobia. Many of your guidebooks are saying it is agoraphobia. It is not agoraphobia. Why? Because you know now. In one situation alone, we will not call it as agoraphobia, 2 or more. Why we have clubbed these situations together and made this diagnosis of agoraphobia? If you see carefully, in all these situations, one thing is common. Patient is developing anxiety. So there is anxiety in situations. Patient is developing anxiety in situations where escape is difficult. Escape is difficult. So patient is having, so while using a public transport, I am using bus, train, metro. What if I get anxiety? How will I get out of it? If I am in big parks, big parking, I cannot see the exit points. How will I go out? If I am stuck in a lift while I am using the lift and I develop anxiety, how will I go out? Okay, if I am in a crowd and I am in a line, how will I go out? Or if I am alone, who will help me? What will happen if I get anxiety? So patient is developing anxiety in situation where escape is difficult. So this is the fundamental concept behind this. Right? So that is why we have made it a separate diagnosis, agoraphobia. Right? We will discuss what is claustrophobia. The next topic will be that we'll discuss. Okay. So this is agoraphobia. Everyone understood? Right. So most common comorbidity. Comorbidity means that patient is having one illness. Sometimes patient may also have simultaneously another condition. So they're comorbid. For example, patient is having hypertension. Many times patient also has diabetes. So those may be comorbid. So which is the most common comorbid psychiatric illness with agoraphobia? Can you name the anxiety disorder we have just discussed? Yes, panic. And it is vice versa. If someone asks you which is the most common comorbidity with panic disorder, you will say it is agoraphobia. So it is seen that patient with agoraphobia also have panic disorder. Very commonly it is seen. So these are, again, and this has been asked also in your MCQ. Okay, this has been asked in your exams. Okay. So write it down. Right? Now, let's come to the treatment. Again, if I ask you, if someone is developing anxiety in particular situation, so just try to tell me, try to answer this question. Someone is developing anxiety in situations. What will be helpful? Therapy will be helpful or pills will be helpful? Therapy. So psychotherapy is better. Okay. Psychotherapy, if you ask me treatment, I'll say psychotherapy. Okay. Psychotherapy will be better. Of course, we can use drugs like SSRIs again, plus minus benzodiazepines. Okay. Of course, we can use pharmacotherapy. Okay. In psychotherapy, so remember CBT, what was CBT? Cognitive behavior therapy. In CBT, there are cognitive techniques to improve the cognition and there are behavior techniques to improve the behavior. So here, especially we use the behavior techniques. So we use the behavior therapy. Okay. And in the behavior therapy, the best behavior therapy is systematic desensitization. Okay. Systematic desensitization, it is the best. Okay. There are other therapies also. There are other, so just understand, we will not go into the details how we do. Basically what we do is, we systematically, stepwise, we try to desensitize the anxiety. So systematically, we desensitize the anxiety. Okay, so there is, again, don't write, just understand if you want to understand. Suppose someone is having anxiety using the lift. I'll do 3 steps, don't write it, just understand. First step, I will tell the patient certain relaxation techniques. I'll teach relaxation. Second, I'll sit with the patient, I'll make a hierarchy. From first situation will be least anxiety provoking, and last will be highest anxiety. So least provoking anxiety situation could be, you are sitting and you're imagining that you are in a lift. This may create anxiety. Second, it could be, second situation can be that patient is just 10 feet away from lift. Third is he's just outside of the lift. Fourth is he's inside the lift but door is open. Fifth situation, he's inside the lift, door is closed. Sixth, he's inside the lift, door closed, lift is going down. And finally, ultimately, he's on the 10th floor and he's using the lift, he's coming down. So this is how we make hierarchy. Once we have made the hierarchy, we go from one step to last step. So first step, he's imagining he's having anxiety. I tell the patient to use the relaxation. He uses relaxation, anxiety comes down. One stage covered, then let's go to second stage. Then again, he uses relaxation. If we are able to overcome, then second. So this is how we go. Ultimately, we reach the final stage. Okay, sometimes anxiety occurs, so we have to go back. So this is systematic desensitization, right? There are other techniques also, just remember the name. Therapeutic graded exposure. It is similar to systematic desensitization. Therapeutically, we are in graded levels, we are giving the exposure. Okay. And one more is flooding. I'll talk about flooding in the next disorder. I'll give you example. Okay. Right? So please at least remember the name. So we are systematically, stepwise, we are desensitizing, decreasing the anxiety. Okay. This is systematic desensitization. Right? Everyone has written this? Yeah, all are behavior therapy. Okay. So you've written this? Right. Next is specific phobia. Specific phobia. Phobia is fear. Specific phobia. Specific phobia. Specific phobia basically is an intense, it's an intense, irrational fear of any object or situation. It's a fear, intense, irrational fear of any object or situation. Suppose there is a small spider here. And one of us, sitting, let us say, very far from that spider, just stands up and says, there is a spider in the class, I cannot attend the class. Very tiny spider. All of us are sitting comfortably, but that person says, I cannot sit in the class, and the person goes out. Until and unless the spider is there, I will not be in the class. Is it a rational fear or an irrational fear? Irrational fear, because this situation does not seem to be harmful. Suppose a tiger enters, all of us starts running. Is it a rational fear? It's a rational fear. So this is what I mean by irrational. That the situation or object does not seem to be that dangerous. Or patient is not that in that close vicinity that he will be harmed. But still the person develops anxiety. So this is specific phobia. That is fear of certain specific situation. Okay. So let us discuss certain named phobias. What is allurophobia? Very good. Allurophobia is fear of cats. Okay, allurophobia. What is acrophobia? Just write acro and put the double sign. Acrobatics. Remember acrobatics, fear of heights. Fear of heights. Algophobia is fear of pain. Good. Algophobia. Now here it is claustrophobia. Very good. Fear of closed spaces. Remember, this was also there in the criteria of agoraphobia, isn't it? So that answer, which the question which was asked, a patient is having anxiety using lift, avoiding lift. Answer was specific phobia. If they are given the name, you can use claustrophobia. So that was answer was specific phobia. If it is to one particular situation. Okay. Can anybody tell me what is cynophobia? Fear of dogs. Very good. Fear of dogs. Okay. What is mysophobia? Fear of germs. Fear of germs. Xenophobia, xenograft, you know xenograft? From a different species, xenografting. So fear of strangers. Fear of strangers. Okay. Zoophobia, very good. Animals. Seeing Avengers. Thanos. The name Thanos is derived from Greek word means death. Thanatophobia is fear of death. Okay. Nyctophobia. Nyctophobia, fear of dark. Very good. Fear of dark. Okay, so there are many named phobias are there. Okay. Right. Okay. You know, situational or unexpected anxiety? It is unexpected, it is situational. If the object or situation is there, only anxiety will occur then. Otherwise not. Okay. Right? So the treatment you can write same as agoraphobia. So I was discussing systemic desensitization. I've discussed flooding. What is flooding? Flooding is to give supramaximal stimulus, excessive. So someone is afraid of spiders. We don't make any hierarchy, don't do anything, just put him in the tense anxiety situation, right? So patient is afraid of dogs, put him in a room full of dogs, lock him from outside. Okay. So what happens is, of course, the dog should not be, there should be friendly dogs. Of course, they should not be that they'll bite him up. Okay. Otherwise you will be sued. Okay. So what happens is, after some time, the anxiety level decreases on its own. But of course, it's not a very ethical method at times. It needs supervision. So if you see, Khatron ke Khiladi, you seen, see that, person goes in the room full of snakes, come out, I, fulfill, overcome my fear. What happens? That is flooding. Okay, of course, those snakes are not harmful. Otherwise, they would not have used them in the show, isn't it? So this is flooding. Okay. So then it's not that there we will use that. Then we will use other therapies like CBT can be used. Thinking can be changed. We can use it in imagination. It's not that if person is fearful of height, I have to take him to height situation. We can do in imagination. We can do in imagination, right? So next is social anxiety disorder. Social anxiety disorder or social phobia. Again, very interesting. Up till now, they have not asked question on this. This is the only anxiety disorder up till now they have not asked question. And let me tell you, in every exam, every alternate exam, question on anxiety disorder are asked. Again, there was a question in 2020, there was a question December 2021, no question on anxiety. You may get a question in this exam. Okay. So what is social anxiety? From the name itself, so there is fear or anxiety, fear of social situations. Okay, from the name itself, the social anxiety or fear of social situation. So why have we not kept it under specific phobia? So it is, occurring, the phobia or anxiety is occurring in certain situation. Why have we not put it under specific phobia? Why we have made a separate diagnosis? Because in specific phobia, patient was fearful of that particular situation. You see a dog, you become fearful. Here, here actually the fear is not of social situation. The fear is actually fear of embarrassment. Very good. Fear of embarrassment. So patient, person says that doctor, when I go to a wedding, I have anxiety. I avoid going to weddings. It's not that just seeing the wedding he'll become anxious. Basically, the anxiety is that what if I do something that will embarrass me in front of others? What if while I'm eating, I'll spill food on my face, which will embarrass? What if I say something, blurt out something which will embarrass in front of others? What if I'm presenting something on stage, I do something which will embarrass me in front of others? So actual fear is fear of embarrassment. So please remember this. Now coming to the treatment. Again, treatment is similar to specific phobia, which is similar to agoraphobia. Same. Okay, therapy. Okay, so therapy. Right? Therapy will be the treatment. Okay. Everyone understood? So all these three, agora, specific phobia and social anxiety disorder, are situational. So in the anxiety question, try to see if it is any situation is given or not. Okay. Last is GAD. A very beautiful question was asked on GAD in December 2020. Such a good question that get confused. Nowadays they give confusing options. They give a lot of confusing options. So GAD is generalized anxiety disorder. The quality of question in psychiatry has significantly improved. Significantly. Okay. They will give you a question, and the thing which will come into your mind, which will be a wrong answer, will be the first option. Okay. They gave a question related to eating. They gave a eating disorder as the first option. The answer was OCD. But if you know the concept, you will be able to answer. But this is how they are framing the question. Okay. So GAD is basically persistent anxiety. Generalized means persistent anxiety, which is not restricted. So continuously patient is having some low anxiety levels. The patient will say, doctor, nowadays throughout the day I'm anxious. I do anything, I get anxiety. I develop a lot of worries. My husband is late from office, I get nervous. I start thinking what would have happened. My children do not reach home, at time, I become anxious. I have to go tomorrow somewhere, I develop anxiety. How will I do everything? So there is anxiety on small things of life. This is generalized anxiety. So anxiety in every sphere. In every sphere of life, there is anxiety. Okay, so this is GAD. So, one important symptom I want you to remember. So, symptoms, one is apprehensions. What are apprehensions? Excessive worries. Very good. Excessive worries. Apprehensive. Patient is apprehensive. The question which was asked was that a female A female patient, worries that her her parents may die in a car accident. This was a simple question. Okay. And one of the options they gave was OCD. Many times when you find this thought, you think of OCD, we come to what is OCD. But there are worries, constant worries, only answer was GAD. A simple question was asked. So please remember, apprehension is a very specific symptom. Of course, other symptoms would always also be present, but apprehension is very, very important symptom, especially in your MCQs. Then there are motor tensions. There may be headache, tension type headache may be there, restlessness may be there, patient is moving around, restlessness is there. So there are motor symptoms also. Okay. And autonomic hyper or overactivity symptoms are also there. Of course, patient is anxious, the sympathetic nervous system is hyperactive. What all symptoms will be there? There may be increased sweating, very good, palpitations may be there. Okay, palpitations, flushing may be there. Okay, so all this application, it was not situational. The next three were situational. They would occur only for some time and go away. Okay, so earlier you can see panic disorder was like this. Come and go. In between patient is all well, isn't it? Then agora, specific and social phobia, they would occur if stimulus is there, anxiety will occur and then it will go away. Patient become all well. Again, if stimulus is there, anxiety will occur, go away. Okay, but it was also occurring like this. But generalized anxiety, the anxiety is although less severe, but it is occurring continuously. This is GAD. Everyone understood this? Okay, so this is GAD. Again, coming to the treatment, you can use drugs. Again, SSRI plus minus. Again, there are other drugs also, but these are the preferred. SSRI are the preferred drug. And then you can use therapy. Which was the therapy of choice for panic disorder? Therapy, psychotherapy of choice, CBT. Same here. So first and last is CBT, rest 3 behavior therapy. Okay, behavior therapy, systematic desensitization. Okay, this is GAD. Yes. No, we can use both. We don't say one specific. In some cases we use CBT, some we use drugs. Okay, so this is GAD, generalized anxiety disorder. Again, this topic is very small, but a lot of questions have been asked. You can expect one question from this topic. Next is again 2019. This question was again, it's a very small topic, but the question was asked. Trauma and stress related disorders. Okay, trauma and stress related disorders. Okay. Now, this table you will not find in your books, but I am giving you this table to understand the concept. So now you can see we are discussing certain disorder, anxiety-like disorder, neurotic disorder, which is related with trauma or stress. Please understand, depression can also occur after a stressful event. But I never told you that depression to occur, you need to have a stressor. Did I say anything like this? No. But for these disorders to occur, you need a stressor. If stressor is there, only then patient will develop symptoms. Otherwise, never patient will develop these symptoms. Okay. So trauma or stress related disorder. Right. So let us divide the stress or trauma into two. One is a major life-threatening event. One is a major life-threatening event. And second is a mild to moderate routine stress. Okay. One type of stress can be a severe stress, other is very mild moderate. Okay. So what kind of severe stress can be there? It can be if the person has witnessed an accident, severe accident. It is important, many of the times they will give in the option. Patient had an accident, roadside accident, he was admitted in the hospital. He was severely injured. So an accident, not a mild accident, a severe accident. Okay. Person experienced war. Okay, so patient, so person either was a victim or he was a soldier, went to a war. War is a very, very stressful situation. Okay, recently there have been so many wars which are going on. In our neighbors only, neighbor of India means, in our neighbors only you are seeing, so much things happening. So people who are suffering there, even the soldiers, they are experiencing this, event. Okay, stressful event. Then there may be a natural disaster. Yes, tsunami. If you remember Gujarat earthquake, so many patients develop this problem. Okay, in fact, we'll discuss one disorder, PTSD. We'll discuss that post-traumatic stress disorder. In fact, this was diagnosed first time when the American soldiers returned from Vietnamese war, from the Vietnam War. So they saw a lot of them were having these symptoms. So yes, so this is how we were able to diagnose for the first time this disorder. Okay, then there may be history of any abuse. Person was kidnapped. Okay, were tortured. Again, those patients, because they are in a very stressful situation. Okay, so these are some important life-threatening events which can cause certain disorders. We'll talk about it. So I'm calling them as major life-threatening event because if it occurred to any of us, most of us will be affected. Okay. Yeah, severe illness, medical, surgical, any illness, but very severe. Okay. While mild to moderate routine stressors are stresses like there is a financial stress, there are financial issues. Okay. So these are the problems which can occur in everyday day-to-day life. Yes. So financial relationships, yes. So relationship problems, there is a breakup. Then there are person has shifted somewhere to a new house, to a new place. Okay. So those things. Okay. And sometimes illness also, medical illness also, but not very severe. Not severe, mild illnesses. Okay, those can also work as a stressor. So we have discussed two types of traumas. So patient who has experienced major life-threatening event can have two types of illnesses. One is acute stress disorder. Acute stress disorder. Second is post-traumatic stress disorder. Okay, or PTSD. So person has experienced a major life-threatening event. He can develop any of these two. Okay. Both are similar in symptoms. The symptoms are similar in both. Okay. CBT has both cognitive and behavior technique, while behavior therapy has only behavior techniques. That is the difference between CBT and behavior therapy. Okay. So you can say behavior therapy is a part of CBT. Okay. Acute stress disorder, from the name itself, it is acute. Symptoms which are developed, symptoms are same, but symptoms which are developed are less than 1 month. Symptoms occur for 1 month and they go away. Okay, symptoms occur for 1 month and they go away. While in PTSD, the symptoms last for more than 1 month. So this is the difference. Okay, so this is the difference. Okay, so this is the difference, right? It can. Maybe this is something, person had an earthquake, again after some days there was another earthquake, but symptoms are developed. So it doesn't matter if it has happened once or twice, if the symptoms are developed, we say patient has developed this disorder. Okay. Then patient who have these mind, now you can see these are the problems which many of us have faced in day-to-day life, but we are not affected. But some patients are affected, some people are affected. Those disorders we call as adjustment disorder. So they have problems in adjusting to new situations. Adjustment disorder. Okay. I'll talk about it briefly about adjustment disorder in the end. The most important disorder here is PTSD. Okay, I'll talk about adjustment disorder in a while. Let's discuss what is PTSD. Very put a hashtag. If question comes from this topic, most likely it will come from this PTSD. In fact, the question has come. So let us know the symptoms. Okay, so when Mahendra Singh Dhoni or Mahi bats, he's a trauma for the opponents. Okay, so the mnemonic is Mahi. Okay, so PTSD. Mood and cognitive symptoms. Now, please understand again, don't go with the criteria. Try to understand what is there in the question which will help you for the diet. Two specific symptoms I want you to remember. But let us understand all of them. So there are mood and cognitive symptoms. So mood symptoms, patient will have a negative mood. So let me give you an example. A 30-year-old male was going to his office in his favorite red car with his best friend. In between, he had a severe accident, roadside accident. He and his friend were admitted. Both were still in the hospital for 15 days and then discharged. But recovery of the patient took another 1 month. Okay, and then patient developed certain symptoms. So let us discuss what all symptoms. So there is a stressful event, right? After which let us see what all symptoms develop. So this patient developed negative mood. He started feeling very sad. Would also become angry at times, would become anxious. So there are negative mood. Okay. So there is a negative emotional state. Also he develops negative thoughts. He developed negative thoughts. Okay. So he started developing, thoughts like I am a bad person. I am bad. I am a bad driver. I am a bad person. Because of me, my friend also got, uninjured. So he developed negative thoughts and negative emotions. Okay. Second is avoidance. This is important. This I want you to remember. Very commonly, this will be given in the question. So the person started avoiding. So there is avoiding. He started avoiding memories. So anytime memory of that event would occur, he would try to avoid it. Or he started avoiding his feeling. He would not discuss his feelings with others. Okay. So his thoughts he started avoiding. He also started avoiding people, places, or objects. So patient is avoiding objects which are related to the trauma, right? Which is related to the trauma. For example, this person, the accident occurred with his best friend. Now he does not want to see his best friend anymore. Because whenever he sees him, all the memories come back. He don't want to touch his favorite car. If he goes to the office, he goes with another route, which takes half an hour more. Because whenever he passes by that same place, again memories come back. Yes, so he's avoiding things, right? Then next is hyperarousal. Again, this is not a very specific symptom, but these are present. Hyperarousal. He's started becoming very irritable. He's now become very alert. Even any noise comes from him, he becomes, what happened? So he's very alert. He has poor concentration, poor sleep. So their hyperarousal symptoms are there, right? And the last set of symptoms are intrusion symptoms. Again, this is very important. Also, you can say the re-experiencing symptoms. Re-experiencing symptom, intrusion symptoms or re-experiencing symptom. Again, this is important. Please at least highlight these 2 points, avoidance and intrusion. So what is happening here is, so he's experiencing some symptoms again, those events again. So how? He's having some dreams. distressing dreams, or he is having what is known as flashback phenomena. He is having flashbacks. So patient will say, doctor, I'm sitting and suddenly that flashback of that entire event comes in front of my eyes. So he's having these re-experiencing symptoms which are causing a lot of distress. Okay, so this is how we make the diagnosis. What is the duration? More than 1 month. So the question which was asked was, a male had a car accident, five weeks after the accident he is reporting of symptoms of flashbacks, distress, he is avoiding situations, diagnosis, PTSD. Okay, so this is PTSD for you. ASD is also same, acute stress disorder, also diagnosed. The symptoms are same, only thing is duration. Symptoms less than 1 month. Okay, so please remember, it's a very important topic, very short topic, very important topic. If you have not understood anything, let me know. Again, in the management, we use pharmacotherapy like SSRI. Okay, so we can use, but psychotherapy is the treatment of choice. Psychotherapy is the treatment of choice. Okay, and in the psychotherapy, CBT is the treatment of choice. It is better. Okay, there is one specific therapy which is used only for PTSD, but I am not saying that it is the therapy of choice. Please understand. But since it is only used for PTSD, you should know what is it. It is EMDR, eye movement desensitization and reprocessing therapy. EMDR. You can write down eye movement So eye movement desensitization and reprocessing therapy, EMDR, right? So basically it is nothing but what we do is we ask the patient to remember or again have the images of that event. While doing it, we give some sensory stimulus, like there is some light stimulus we give, and gradually we have seen that this desensitizes the anxiety. Okay, EMDR. But the therapy of choice is CBT. So this is PTSD. This is PTSD. Please remember this, again very important. Okay. EMDR is eye movement desensitization and reprocessing therapy. Okay. Everyone understood this? Everyone written? Okay. So this was what I want you to know, but just understand this concept of adjustment disorder. Patient has mild emotional and behavioral symptoms. Mild symptoms. So in the question you may get, patient has shifted to a new house and he is developing some symptoms like irritable, decreased sleep. Okay, he has joined a new office. Okay, person has got married. Again, it's a new situation for him. Okay, so every new situation we say takes time to adjust. Some people adjust, with less time. Some take time. So this is adjustment disorder. If patient is having symptoms, then we call it as adjustment disorder. Adjustment disorder is the disorder of exclusion. What do we mean by disorder of exclusion? Rule out other disorders first. Rule out other disorders. If you find that there is no other disorder which is there but symptoms are there, then you call it as adjustment disorder. Why I am telling you this? You may get less likely, but still, because nowadays it is not very difficult to predict, you may get because a good question can be framed from this adjustment. Let me give you a scenario. A 30-year-old male, he is recently joined a new job. And since past 20 days, he is complaining of decreased mood or sad mood, decreased interest, decreased sleep, decreased energy, decreased appetite. Diagnosis. Can any other diagnosis be a better fit to this? It is depression. So don't think only the stressor, see the events. That's what I'm saying. Even if the stressor is there, but try to see if there is other disorder. Is fulfilling disorder of depression more than 2 weeks, the symptoms, all of symptoms are there, isn't it? It's a depressive disorder. When they will give you a adjustment disorder, there will be, let us say, a new job, and they will say he's just having irritability, he's having decreased sleep. Just few symptoms. You cannot say it is depression, then you will call it as adjustment disorder. Everyone understood? Yes. Again, in the treatment, we can use CBT. Sometimes, if required, we can also use drugs. Okay. Right. So this is the slide for trauma and stress related disorder. Just have a look. Okay. So again, this is very, very important topic. Please remember, PTSD is very, very important, has been asked. Yeah. Treatment CBT, and if required, we can also use drugs. Next topic is obsessive compulsive and related disorder. Okay. We'll take a break in another 10 minutes. We'll take a break. Okay. OCD. So obsessive compulsive. This is a new term in DSM-5. So very important. Please remember this. Obsessive compulsive and related disorder. Okay. So DSM-5, what it has done is, it has combined picked up certain disorders and kept them under this term. So it said that there are certain disorders which are similar. So let's keep all of them in this umbrella term. Okay. So OC and related disorder. So there are 5 disorders. One is very important. Next 4, I'll just name them. We'll just name them and I'll just tell you what are these. Yes. OC and related disorder, right? First is obsessive compulsive disorder. Very, very important topic. Okay. Very, very important topic. Yeah, in adjustment disorder, treatment was CBT, and also we can use, sometimes if required, drugs we can use. Okay, CBT, cognitive behavior therapy, right? So let's come to OCD. So from the name itself, there is obsession and there is compulsion, right? Twice they have asked question on OCD, again 2020. Once they had asked question on OCD. Second, OCD was one of the options. Okay, so and it was a very confusing question. Okay, so let us discuss what is OCD. So there are obsessions. Obsession is a disorder of thought. Very good. Under thought which? Flow. Very good. Possession. Remember we discussed this. So what is obsession? Obsession are repetitive thoughts, images or impulses. Okay. Repetitive thought, images or impulses which are patient's own. Remember we discussed patient says, doctor, I know these are my own thoughts. These are patient's own thought, right? But these are senseless. Patient knows that these are irrational thoughts. These thoughts are wrong. A delusional patient will never say what I am thinking is wrong. He will say, no, I know the neighbor wants to kill me. How? What are you saying? He will not say, no, doctor, I am getting this thought, but I know this is wrong. No, he will not. He will be happy in his delusion. But a person with obsession will say, doctor, I know this thought is my own thought and it is wrong thought. I don't want to have this thought. Okay. So for him, it is a senseless thought which is very distressing. It is causing distress, or it is a very distressing thought. Is the patient able to resist? Patient is not able to resist this. So patient is not able to resist these thoughts, images or impulses. Okay. So this is what is known as, this is obsession. So I'll discuss various examples of obsession when we come to types of obsessions. One very common obsession we have discussed is contamination. Doctor, I get these repeated thoughts, my hands are dirty. This is my own thought. But I know this is senseless because my hands are clean. It is very distressing, doctor. 10 hours, 8 hours in the day I am getting this thought. So you can understand, 8 hours you are having this thought. Very distressful. And I am not able to control. Okay. We'll discuss various obsessions. One term I want you to remember for obsession is ego. So one term which I want you to remember is ego dystonic. Or sometimes also known as ego alien. Ego dystonic or ego alien. Ego means mind. Ego means mind, right? Ego means mind. Dystonic means that they're very distressing. They're unacceptable or unwanted. Okay, ego dystonic. So whenever you hear this term ego dystonia or ego dystonic, it is related to obsessive compulsive disorder. So these thoughts are unacceptable or unwanted by the mind. So ego dystonia, ego alien is a term used for OCD. Please remember this. This has been asked previously. While delusion is ego-symptomic, the mind is very happy. The patient with delusion is very happy thinking what he is thinking. He's not having distress related to the thought. Okay. So this is obsession. Next is compulsion. Okay. Next is compulsion. So just discuss compulsion and then we'll take a break. Okay. So compulsion is repetitive. Okay, it's a repetitive behavior. So compulsions are repetitive behavior or acts. Repetitive behavior or acts, and sometimes or most of the time it is secondary to obsession. Not always. Sometimes compulsions can occur individually, independently also, but most of the time they'll occur secondary to obsession. So this patient who is having this thought that my hands are dirty, he's getting a lot of anxiety, what he will do? He will go and start washing. So washing becomes a compulsive behavior. But it does not mean that after washing his anxiety will go. Again he will, again thought will come, again he will wash. So family members will say, come, please help us. The full tank of the society he uses in hand washing. One soap every day he uses for hand washing. 8 hours, 10 hours straight he is in the washroom. This is very distressing for the patient. If you can understand the dilemma which patient is going through. He knows he is having problem and he is not able to control. Okay, so this is obsessive compulsive disorder. Let's take a break. Let's start at 2:30. Discuss obsessive compulsive disorder. We have discussed what are obsessions and what are compulsions. Right? So compulsions, I told you, these are repetitive behaviors or act which can occur secondary to obsession or sometimes even without obsession they can occur. Okay. Right? So before discussing various types, what are the various types of obsessions and compulsions? So in the patient there can be 3 types. When patient can have both obsession and compulsion. So one patient is having both obsession and compulsion. Some patients only have obsessions. Again, we will call it as OCD only. Okay, we will call it as OCD only, just that the patient is having only obsession. And sometimes, less commonly, patient can only have compulsions, right? Can only have compulsions, right? Okay, so this is Okay. So in the question, if you're only getting obsession, then also it is OCD. Only compulsion, then also OCD. If both, of course, OCD. Right? Okay. So let us discuss various types. So there are many types of obsessions and compulsions which we can find in the patient. Okay. So which is the most common obsession? Most common obsession is, we have already discussed, contamination. Very good, contamination. Okay, so patient gets repeated thoughts that my hands are dirty, things around me are dirty. Okay, so these can be, when I walk on the road, patient gets this thought that dirt is coming over my body has become dirty. Although patient knows that this is not right, this is irrational, but this thought comes again and again. Okay, so this is the most common. Once there was a question in which they asked which is the most common obsession. Okay, and in that they did not give contamination as the option. So you should also know this is the second most common. Which is the second most common obsession? Pathological doubts. So patient gets these doubts. Patient goes out of the room. Patient goes out of the room. Patient gets this doubt whether I switched off the light or not. Patient will say, doctor, I know I switched off the light. I remember. But this thought occurs again and again whether I switched off the light or not. Patient says, doctor, I go out of the room, I get this thought whether I bolted the door or not. Okay. So, doctor, I am going to my office, but this thought is happening again and again. That whether I lock the door or not. So much so that halfway I have to come and check. Multiple times I have to do this. Okay, so this is pathological doubts. Patient is having repeated doubts. Then other is need for symmetry. Okay, or you can say precision. So patient get this repeated thoughts that everything should be in order. Doctor, the books in my shelf should be in order. They should be placed alphabetically. Things on my table should be in order. Everything should be arranged properly. If someone just moves it somehow, repeated thoughts occurs in my mind that it's not in order. So everything should be in precision. Okay, so this doubt occurs again and again. Okay, so this is need for symmetry. Sometimes patient gets aggressive obsession. Doctor, I get this repeated thought that I should slap the person standing in front of me. Doctor, I don't want to do this. Why would I do that? But this thought is occurring again and again. I am not able to control. Okay. And sometimes even sexual obsessions may occur. Patient gets this thought, doctor, I get this repeated thought that I should touch the opposite gender inappropriately. I don't want to do this. But this thought is occurring again and again. I am not able to control this thought. Okay. So these are some types of obsessions. Please understand it's not necessary patient will have one obsession. Can have multiple obsessions. Thoughts towards God. Again, in this sometimes, thought towards God are very common. Patient says, doctor, I get very, such thoughts towards God. I am urinating in front of the idol of God. I'm spitting on God. I get this repeated thought. I don't want to do this, but these are happening again and again. This is obsession. Please remember most common. Also do remember second most common. And clinical scenario, you should remember of everything. Because I'll tell you what question was asked. So these were the obsessions. Can anybody tell me which is the most common compulsion? Yes, C for compulsion, C for checking. Okay. Okay, so checking is the most common. So what is happening in checking? So patient who was having pathological doubt, whether I switch off the light, switch off the door, whether I bolted the door, that patient will say, doctor, I am midway in my office, I come back, I check. Again I go, I come back and check. Again I go. It's not once or twice, 20, 30, 40 times I do this. Still, it occurs again and again. Okay, so checking is the most common. No. Reaching the goal would mean that anxiety will go away, but since it's a disorder, anxiety does not go. Right? Second is, what is the person doing when he's having obsession of contamination? is cleaning or washing. Very good. So, we have a patient, recently, again, that patient recently we saw he is now showing much improvement. But, when he came to the first time to us, he said that, I had this thought that I am dirty. When I come back home, there is dirt all over my body. The wife has a very typical complaint. Doctor, whenever he comes back, I go shopping and we bring food. He always asks me to go and take a shower. Why should I take shower? But he says that you are also become dirty because of dirt. Go and take shower. So now recently when we met her, he said, the wife is happy. But no longer I am forced to, take a bath again. Okay. So yes, sometimes family members are also important. Very, very, very distressing for the family members also at times. Okay. So wash. Right? So this is the second most common. Please remember this. Next is counting. Okay. Next is counting. So patient has repeated, repeated these counting things again and again. I'm counting money. Again, I think I want to count it well. I'll again start counting. So they're counting again and again. Okay. So counting. Next is, so when someone is having obsession of symmetry or precision, what is he doing? He also start doing symmetry, things symmetrically. So there is symmetry, the compulsion of symmetry or precision. So this person who is getting repeated thoughts that everything should be in symmetry, now he also starts arranging things. Throughout the day, he's just arranging things. No, he'll arrange his, cupboard, someone has just misplaced certain thing, he'll arrange, take 2 hours to arrange his cupboard. Keep on arranging. If someone has just disturbed it, and it's like this, someone has twisted, oh, it should be the right position, twist it like this. Until unless he does not do it, his mind will keep on having these thoughts. Okay. A very good question which was asked recently in your FMG exam. The question was, a person is eating food. Okay, a person is eating food, then he is eating every piece is cutting in equal proportions, and then he is eating. This was the question in your exam. One option was a eating disorder. Please understand, we are not talking about eating disorder. We discuss what are eating disorder, but here he is doing things symmetrically. That means he is having this compulsive behavior. It is OCD. Okay. So what happens when someone is doing things symmetrically? Precision, there will be slowing. He will do everything very slowly. So the question said that he is taking a lot of time eating his meal. Okay. So there is slowness or there is slowing. Okay. So these are some common, obsessions and compulsion. Do remember also the most commons. So the question which was asked from this. So please see, questions are asked on these topics. So very, very important. This is very important. Okay. So this is very important. Now is it clear? Yeah. In the chat box, please let me know if the voice is clear now. Okay. Okay. So let me see. I think. Okay. So this is frequency of obsession and compulsions. Okay, I'll just repeat. So of compulsions, checking is there. The person is checking things again and again. Washing is washing. Then he's counting things again and again. In symmetry and precision, everything which he's doing is in precision. Okay, everything which he's doing is in precision. So these were the most common obsessions and compulsions. Okay, so these were the most common obsessions and compulsions. Right? Now let us come to the treatment. Let us come to the treatment part. Okay. So in the treatment, one is the pharmacotherapy or the drugs. So one is the drugs. Again, what are the drugs? Drug of choice is, can anybody tell me? What is the drug of choice? SSRI. SSRI are the drug of choice. Okay. So SSRI is like, we have discussed already, like fluoxetine. Like fluoxetine. Okay. So drugs like fluoxetine. There is one SSRI. There is one SSRI which we say is not useful for depression, but it is useful for OCD. Which is that drug? It is Fluvoxamine. Fluvoxamine. But please understand, I am not saying that fluvoxamine is the drug of choice. I am saying SSRIs are the drug of choice. But there is one SSRI which we don't use in depression, but we use in OCD. Okay. Then other drugs like sertraline, and so on. So all these drugs can be used. Now, there is one more drug which we say is again, the first line drug. So one is SSRI we can use. Another drug which we can use is a TCA. Only one TCA is approved for OCD. So it is clomipramine. Clomipramine is a tricyclic antidepressant. Only TCA which is approved for OCD. But still, if you have to choose one, answer is SSRI. This has been a very old question. Many books have given it wrong. Many books have given the answer as clomipramine. But if SSRIs are there in the option, answer will be SSRI. Okay. Tricyclic antidepressant. Okay. TCA. Tricyclic antidepressant. Okay. Now, sometimes when patient does not show improvement or less improvement, we also use some add-on treatment. We also use certain treatment which are add-on treatment. Okay, one very important drug we can use are antipsychotics. Antipsychotics, again, please remember, antipsychotics can be used as an adjuvant therapy, as an add-on therapy. Okay, it can be used as an add-on therapy. Drugs like risperidone. Okay. Drugs like risperidone can be used. And other drugs also, aripiprazole, these can be used. So if you are asked, if I ask you, can antipsychotics be used as an off-label use for OCD? Yes. Antipsychotics, sorry, not antidepressant, antipsychotics. They can be used as an off-label use. SSRI we have already used. Okay. So everyone understood this? This was the question which was asked recently in some other exams. So please remember this. Okay. So we can use antipsychotic even in dementia. We can use antipsychotic even in OCD. Okay. We also use antipsychotics in bipolar disorder. Do we use antipsychotic in PTSD? PTSD? No, that was the answer. So they are given 4 options. In which of the following antipsychotics are not used off-label use? Okay. Options were dementia, bipolar disorder, then it was PTSD, and then it was OCD. Answer was PTSD. Okay. Next is psychotherapy. So in psychotherapy, the psychotherapy of choice is CBT. Very good. If you have to choose one, the therapy of choice is exposure and response prevention. In a recently conducted exam, INICET, are you aware of this exam? But this simple question was asked. So they're asking question on this OCD. They asked, the patient is having symptoms, it was OCD, which is the therapy. It was ERP was there in the option. Exposure, so we are exposing the patient from the stimulant which is causing anxiety, and we are preventing the response. So exposure and response prevention. Okay, exposure and response prevention. This is ERP, right? Now, so this was about the management. If I ask you treatment of choice for OCD. What is the treatment? This has been asked previously. It is combination. Very good. It is drugs. Very good. It is both drugs and therapy. Very good. So if you are asked, you can, or they can say SSRI. Of course, we can use benzodiazepine plus minus plus CBT, especially ERP. If they have given, they have specifically asked ERP in the option. Look, suppose they give CBT and ERP both. Choose ERP. It's a better, more specific answer. Okay. Right? So again, this is a very, very important point about OCD. Very important. Right? Okay, so this was OCD. This is OCD. So write it down. Okay, so with the topic, what was the topic which we had started? Obsessive compulsive related disorder. Okay, obsessive compulsive related disorder. So let us understand what are the other disorders which are included under this. So one question which they can ask is, which of the following is not included under obsessive compulsive and related disorder? One was OCD, then there are others also. Let us discuss. Briefly we will discuss. Okay, so one is body dysmorphic disorder. Body dysmorphic disorder. So what is body? From the name itself, there is some dysmorphic characteristic in the body. So patient is having repeated thoughts. There is preoccupation with an imagined body defect. So patient may say, doctor, I think my nose is large. I think my nose is small. I think my ears are large. My ears are small. Okay, but patient is not totally convinced. He's not saying, no, doctor, I know it is large. No. He's saying, I think I am getting this thought that this, so somehow it may be defective. What is this? Body dysmorphic disorder. What was a similar condition we have discussed previously? Delusion of dysmorphophobia. Up till now, there has been no question in any exam in which they have given both the options. So the question answer becomes easy. But if they give both the options, when we will call it delusion? When the person is not getting convinced. He has visited many surgeons, plastic surgeons, family members have tried to convince, he is not getting convinced. Then it will be delusional disorder. Okay. If he is getting convinced, so patient may come to me and say, doctor, I am getting this thought. Sometimes I feel yes, it is large, but sometimes I feel that I am thinking a lot. So they would come to you and may ask for help. Okay. So this is body dysmorphic disorder. Most common area which is affected. Most common area of concern here is first is hair. Second is important, you should remember nose. Hair may not be there in the option, so then you have to go with nose. Okay. Again, treatment, we can use drugs like SSRIs. We can use therapy like CBT. Okay, those can be used. But you should know what is body dysmorphic disorder. Okay, you should know what is body dysmorphic disorder. Important, very simple question can come from this topic. We'll just give a clinical scenario, you have to choose what is the answer, right? Next is, everyone has written this? Yes. Great. So, hoarding disorder. What is the meaning of hoarding? To keep on collecting. Okay, keep on collecting, hoard things. Okay. The old movies you will see that, that the shopkeeper is a hoarded things, not giving to the poor people. So that is hoarding. Keep on collecting. So hoarding is acquiring and not discarding things which are deemed to be of little or no value. Someone is hoarding money, don't call it as hoarding disorder. Okay. So things which are of very little or no value. Person is just collecting them and not discarding them. Do you still have the pencil box you were using in your first standard? There's no use now. We discard it, isn't it? We discard things which are not of use. What if a person who go to a place, patient, person say, I'm carrying all the pencil boxes I used in my life. All the school books I have till now. He's 40-year-old, he's still carrying his nursery book. Okay. Or if he's carrying magazines, last 10 years all the magazines he's carrying. Okay, so it's a disorder because now it is causing a lot of distress. Many of us may be collecting certain things, don't start feeling I'm having hoarding disorder. If it is a disorder, it will lead to functioning impairment. You go to the house of that person, you may not find any place to sit. Okay, so this is hoarding. So items like newspaper, they may collect newspaper, books. So any such thing. A lot of our grandparents, collecting so many utensils. You'll find what will you do? No, I want it. So they keep on collecting things which are of no value or very little value. Okay. Now please understand one point I want you to remember about this. In the treatment, hoarding disorder was earlier a part of OCD. It was a type of OCD. Now they have separated it, made it a separate diagnosis. One of the reasons is that, please remember about the treatment. The treatment is difficult, or you can say they are difficult to treat. One question which was asked, the question was asked was CBT is less useful for washing, contamination, checking, hoarding. Okay, so treating hoarding disorder is slightly difficult because patient does not always show good response. But still, if you have to choose, you can start with CBT. Drugs may be used, but CBT is a better option. Okay, CBT is a better option. So this is hoarding disorder. So this point I want you to remember. You can expect a question like this. Okay, so just few points of every topic you should remember. It is difficult to treat, right? Then it is hair pulling disorder. Hair pulling disorder. So again, it is also known as tricho. Very good. Tilomania. Tricho means hair. Trichotillomania. Okay, trichotillomania. Okay. So hair pulling disorder, you can remember, you can see there is repetitive hair pulling. There is repetitive hair pulling leading to variable hair loss. Tell me, so hair loss can also occur because of dermatological condition, isn't it? Clinically, just by seeing, can you tell me, will you be able to say whether it is because of hair pulling or because of some other condition, medical condition? How? Yes, it will be irregular. The alopecia will be irregular. The hair which will be falling will be in different stages. Okay, the length will be different. While a person having alopecia because of a general or a medical condition will have a clear patch. Okay, so clinically you can also you'll be able to see whether it is hair pulling or not. Okay. Okay. Before body dysmorphic disorder, this was the slide before body dysmorphic disorder. Okay, where we discussed treatment of choice. Now we are discussing hair pulling disorder. Okay, again treatment we can do, therapy, drugs we can use. Okay. Next is, so don't worry about the treatment, understand the condition. Next is excoriation. Next is excoriation or skin picking disorder. Excoriation or skin picking disorder. From the name itself, now what the patient is doing? Picking the skin. Picking the skin. Okay, so rather than hair, now person is picking. No, in hair pulling disorder, please understand, the scalp here, you can just write down most common area in hair pulling disorder is the scalp. But please remember, the hair can be plucked from anywhere. It can be armpit, from the chest, and even the pubic hair. So any hair from any part of the body, person can pull. Okay. Most common is scalp. Most common area is scalp. Excoriation or skin picking disorder. From the name itself, patient is recurrently doing skin picking. So he's picking the skin, maybe from his nails, biting from his teeth, he's picking the skin. You'll see there is a lot of skin lesions resulting in skin lesions. Again, these patients will first go to a dermatologist. Okay, dermatologist will take a good history and then may refer to the psychiatrist. Okay. Most common area which is affected is face. Most common area which is affected is face. Again, we can use drugs, we can use therapy. Okay. So I hope now all of us know what are the important disorders under obsessive compulsive and related disorder. Let us name one by one. First is OCD. Second, body dysmorphic disorder. Third, loading disorder. Fourth, hair pulling disorder. Fifth, skin picking disorder, exfoliation disorder. You should remember the name at least. Simple question may come, which of the following is not. You should know what are included. Okay. So that is why now you can see everything patient is doing again and again. That is why they club them together. All these disorders have certain things which have been repeated again and again, isn't it? So that is why they have clubbed them together. This was about OC and related disorder. Just few words about this one more problem again we are discussing here because it is also similar. Impulse control disorder. Impulse control. Treatment is therapy. Again, I am not writing treatment. Drugs we can use. Like SSRI again we can use therapy. Like CBT, those we can use. Okay. Right? Drugs in SSRI we can use in therapy. Now, impulse control disorder. Impulse control disorder, again, you can see from the name, person is not able to control his impulses. Okay. So, there may be many impulse control disorder. Two, I want you to remember at least. One is pyromania. What is the meaning of pyre? Fire. Very good. So, it is basically recurrent and purposeful setting of fire. Purposeful, not accidental. Purposefully. So patient says, doctor, I get this repeated impulse to set fire. I get this impulse. And I am not able to control this. So this person what he may do, go to his office, find a corner, put all the furniture there, set fire. It's not because he's angry with his boss. It's because he's not able to control. Okay, he's not, until he does not do this, this anxiety keeps on building. So this is impulse control disorder, pyromania. Right? Next is kleptomania. There was a, I think, story in English we would read in our school days about kleptomania. What is kleptomania? It is recurrent stealing of objects. So patient says, doctor, I get this repeated impulse to steal objects. Okay, recurrent stealing of objects which are not needed for personal use or for monetary value. So this object which the person is stealing can be a 10 rupee thing or can be a 1 crore thing. But purpose of stealing is not monetary. He may just steal it and throw it away, or just keep it somewhere, does not use it. Okay, because the act of stealing is important. He is not able to stop that. If he is using it for monetary benefit, it is not disorder, it's theft, it's a crime. But person with kleptomania should not be kept behind the bar, he should be treated because it's a disorder. Okay. So these are important impulses. So again, they are similar to the above ones. So we are discussing here. So this was impulse. So simple direct questions on both have been asked previously. Pyromania, kleptomania, both you will find question in your previous year exam. Okay. So both have been asked. Okay. So this was about OC and related disorder. Next set of disorder which we are going to discuss today, the last group of disorder which we are going to discuss today are somatoform and related disorders. Somatoform and related disorders. Okay. I'll give you a trick to understand because there is a lot of confusion when you talk about dissociation, somatoform, hypochondriasis. They appear very similar. So first of all, whatever disorder I am going to talk about now, they will appear to be physical in nature. Doctor, I am having headache. Okay. Doctor, I am not able to move my body. I am having convulsions. These will appear to be physical, but these are basically problems of the mind. Okay, so you may find this, you find a question, medical symptoms will be given, but ultimately answer is psychiatry. Okay, so what are these symptoms? These are basically unconscious symptoms. Unconscious means, please understand, these symptoms patient is not producing deliberately. There is no intention to produce or feign these symptoms. No intention is involved. Patient deliberately is not doing this. Okay, patient says, doctor, I am having pain in my abdomen. You get all the investigation done, everything comes out to be normal, but still the patient is having pain. Ultimately, the gastroenterologist may refer this patient to the psychiatrist. Because sometimes there is so much stress in the mind which produces these symptoms. So patient is not aware, patient is not deliberately doing. Please remember, many of us, in school days, you have exam tomorrow, you will say, oh, I am having headache, I am having pain. But that is deliberate. You don't want to go to office, you say, I am having fever. Although you're not having fever, but you're saying it is false. That is deliberate, that is conscious. Here it is unconscious, patient is not aware. How do we get to know that these are unconscious symptoms? What will be the clues in the question? So clues will be, they will say patient has come to these symptoms. Examination, you have examined the patient, normal. The doctor has done examination, it is normal. You have investigated the patient, it is normal. And sometimes stressor may also be given. It's a plus minus. You may be given, mostly they will give you, but sometimes they may not give you. Okay. So when I'm talking about these disorders, they have unconscious symptoms. So in the question, they will not tell you he's having unconscious symptoms. You have to infer. You have to see. So examination normal, investigation normal, stressor may or may not be there. These are the clues. So these are the clues. So patient has symptoms, bodily symptoms, but the cause is not physical. Doctor, I am not able to move my limb. I am not able to move my hand. You will feel, oh my God, there is paralysis. But you investigate, you examine, everything is normal. So it is maybe because of stress in the mind has produced this symptom. It is nowhere physically, it's just a symptom of the mind. Okay, you do therapy, patient able to move the limb. Okay, everyone understood? So there are three disorders which we are going to discuss here. One is dissociative disorders. First is dissociative disorders. Okay. So what is dissociation means? Dissociation means there is a disturbance in the normal integrated functions of. So there are many functions of the mind. One function is getting separated from the other functions. This question was asked in your FMG exam. What is dissociation? This question was asked in 2018. Dissociation, disturbance in the normally integrated function of consciousness. So his consciousness is separated from other functions, identity or memory. Okay, and write it down, then when we discuss the disorders, you will be able to appreciate well. Okay, so one function of the mind is separated from the other function. That means there is problem in one function of the mind. Okay, this is dissociation. First is dissociative amnesia. What was amnesia? Loss of memory. We have discussed organic disorders. We know in amnesia there were causes, CNS causes, systemic causes. But here, this type of amnesia does not have any physical cause. So what is happening here is inability to recall important autobiographical information, that is information about oneself, about one's own life events. So inability to recall important autobiographical information, which is usually traumatic or stressful in nature. You can write just one term, usually it is traumatic or stressful in nature. Okay. So, but we are not able to find any organic cause. Okay. It is inconsistent with the organic causes. For example, a newlywed husband and wife, they were just married 6 months back. The husband and wife In the middle of the night, they are having some argument. The argument escalated to such a level, the husband says, I don't want to live with you, I want a divorce. After some time, within few minutes, wife started saying to him, who are you? Where am I? I don't know who are you. Call the police. You are a stranger. Mother-in-law, father-in-law come rushing. What happened to our sister, our daughter-in-law? She says, who are you people? I don't know you. Please take me to my home. Call my parents. So parents were called. She recognized them, hugs them, tells them, please take me home. Where have you sent me? I don't know which place is this. She says, I have an exam tomorrow. I want to go home. 6 months back, there was an exam after which she got married. She forgot all the event of that marriage. Everything got erased. Okay, so there is no physical condition that can explain this. She was taken to the hospital, investigation, CT scan, MRI, everything normal. So there was stress. Mind was not able to bear the stress, so it converted the stress into amnesia. So that memory got disintegrated. So other things she remembers. Everything else she is able to do. Only that stressful event she is not able to remember. So this is a classical example of dissociative amnesia. I hope all of you now understand this. Okay, treatment will be therapy. So I'm not writing treatment again and again. Treatment will be, most of them, treatment will be therapy. Many types of therapy we can use. Treatment is therapy. Okay, right? Okay. So this is dissociative amnesia, right? Everyone has written this. Next is dissociative fugue. Dissociative fugue. It is a purposeful travel. Write it down. It's a purposeful travel beyond the usual range, usual everyday range. What is the usual everyday range travel you do? You go to your home, come back to the class, go to the grocery shop, go to your office. So this is the usual daily range travel which you do. But this traveling is beyond this usual range travel. 1 point. Right? Second is, it may have features of amnesia. So it may have features of amnesia, and the person may assume a new identity. Patient or person may assume a new identity. Okay, this is dissociative fugue. I'll give you an example. Okay. So there is purposeful travel. Patient travels to some area, a long distant area. He has amnesia of his past event, past life, and he develops a new identity. Okay. But again, everything is not doing it deliberately. Please remember, he is not doing it consciously. The mind has done it, does not remember. Okay, he actually does not remember. So what happens? There was a gentleman, Mr. A. He was living in Delhi. He got bankrupt. Okay, so he was a businessman. He got bankrupt, and he went missing. Family do not know where he is. He went missing. Okay, so he had a lot of big stressor was there. He went missing. 6 months later, one of his friend who went to Kerala, okay, identified a person who is looking like Mr. A. He approached him and said, "Oh, what are you doing in Kerala? You know, your family is waiting for you. Let's go back. Let's come back. Don't worry. We'll solve the problem." He says to this person, "Who are you? I don't know you. Who is this Mr. A? I am Mr. K. I live here." Okay. So what happened is that he has traveled far away. There is amnesia of his past event, and he has formed a new identity. Again, please remember, he is not doing it deliberately, intentional. Nahi hai. This the mind is doing. We put this patient under therapy. Slowly and steadily, he may be able to remember things. Okay, so this is dissociative fugue, right? This is dissociative fugue. Everyone understood? This is dissociative fugue. Then next is trance and possession. Very interesting. Trance and possession. What is trance? Trance is basically temporary loss. Temporary loss of both sense of personal identity and awareness of surrounding. So there is a temporary loss of identity and surroundings temporarily. And patient acts as if the person is taken over by a spirit. Some spirit has entered the body. For some time, patient loses touch with awareness with the surroundings and himself, and may act as if the person is taken over by a spirit. So this husband-wife, newly married husband-wife, so wife started remembering again. She came back, things settled down, but again 1 year later things became bad. So one day they were there in a festival, Jagran, night religious things which happen. So they were there, and suddenly this wife started acting inappropriately. She loosened up hair and she started saying, called her husband, come here, Kapoor, and gave him a tight slap. What are you doing to your wife? She called her mother-in-law, come here. I am your mother-in-law who come from heaven. What are you doing to your daughter-in-law? Half an hour later, the wife comes into senses and sees what happened. She does not remember anything. Sees her husband like this. And she says, what happened? Please come here. He does not come near. Okay. So this is a classical example of trance and possession. She is, yeah. Yeah. So if you've seen this movie and the Hindi adaptation of this movie. Seen this movie? Classical example of trance and possession. The heroine thinks that she's been possessed by a queen, spirit of the queen who lived years back, and the hero is shown to be a therapist. He eventually treats her. So these are not very common disorders. Please understand, these are not very common disorders, but yes, they can be asked. Right? Husband and wife. I was giving the example, right? So next, yeah. So you do therapy, things will become better. Okay? Right? Okay? Next is depersonalization, derealization. From the name itself, depersonalization is detachment. Personalize means detachment. Okay, so patient feels, doctor, I feel as if I'm detached from myself. As if I am watching myself in a movie. Things appear very unreal to me. This is a feeling which the patient has. This is depersonalization. D means detachment. Personalization means from the self. So patient uses this term as if. So in the question, many a times you will get this term. So patient will say as if, I'm detached from myself. This is a feeling. In autoscopy, he was seeing himself. That is autoscopy. He's just saying, doctor, I feel like that I'm detached from myself. It's just a feeling. Okay. Derealization is detachment, from the reality. Detachment from the environment. Okay. So I feel detached from my environment. Again, the patient will use this as a phenomenon. Okay. So patient will use this as a phenomenon. Okay. So this is depersonalization and derealization, right? Okay. Next is dissociative identity disorder or multiple personality disorder. Dissociative identity disorder. Yes, after treatment and dissociative amnesia, patient will be able to remember. Yes, most of the time patient remembers. So dissociative identity or multiple personality disorder, what is happening? There is presence of two or more personalities in one person. So one person is having two or more personalities, and these personalities are unaware of each other. Sometimes, but generally we say unaware, not totally aware. Okay, but most of the time they are unaware. What the other personality did, the other personality will not be able to know. Most of the time, right? So, for example, there is a person who is very coward, very timid, is in office. Anyone can shout on him. He's traveling in his car. Someone scratches his car. He gets a bat and start beating that person. So it seems to have two personalities, and one personality is not aware of the other personality. Okay, so just like you see in the movie Mask, he wears the mask and converts to someone else. Okay, yes, opportunity, yes, very good. Yes, this movie. Okay, if you see any recent Amazon series, yes, in which if you're not seen, then it's a spoiler alert. So yes, I will not say again. It's a series in Amazon. Abhishek Bachchan, classical exam. Classical. Don't go and start watching that. Okay, but classic. Okay, again, these are not very common. There are case reports. There are case reports of someone having 50 personalities in one individual. 50 also. At least 2. Okay, so this is dissociative identity disorder. This was dissociation. Let's come back. Yes, Fred. Yes. So next is conversion disorder. We have covered dissociative disorder. Let's finish this topic. Conversion disorder. It is in DSM-5. It is known as functional neurological symptom disorder. Functional neurological symptom disorder. So such a good name they have given, very apt name. Here now what is happening, the symptoms are neurological in nature. So we know, so these are neurological symptoms which are functional, no organic cause. So functional neurological symptom disorder. This is the term used for conversion disorder in DSM-5. Okay. So these can be sensory symptoms. Okay, for example, patient is having, numbness. Patient is having numbness, blindness. So this husband and wife, again, they get into fight. Then suddenly in the middle of the fight, the wife starts saying, I am not able to see anything. She's taken to the hospital emergency, ophthalmologist is called, every investigation, that everything is done, everything is normal. Stress is decreased, therapy is done, she starts seeing again. She's not deliberately saying that she's not able to see, actually, she's not able to see. Okay, because of stress. Okay, so these are unconscious symptoms, right? So they may be sensory symptoms, they may be motor symptoms like paralysis. Okay, like pseudo seizures, not true seizure, pseudo seizure. These will always occur in the presence of someone. True seizures can occur even alone. True seizures can occur in sleep, they will not occur in sleep. Okay? Yes. No such thing will occur in pseudo seizures. No injury will be there. Okay? Yeah. Okay? Okay? There is one important interesting term which I want you to remember is what is known as la bella indifference. What is la bella indifference? Careless attitude. Careless attitude to serious symptoms. There is a careless attitude to the serious. So patient is turned blind. No, just imagine if any of us is not able to see for a few seconds, will become very anxious, restless. But this patient who is saying I'm not able to see, she is sitting very calmly. I'm not able to see. Very calmly. Okay, there is no sense of, that seriousness is not there. Okay, so this is la bella indifference. This is the indifference. indifference to the serious symptoms. This is La Bella indifference. Okay. So everyone understood. Again, this has been asked as a question in your exam. La Bella indifference. Last of the disorder is, so everyone has written this. Last is somatoform disorders. Somatoform disorders. Okay. So last is somatoform disorders. Under somatoform disorders, we will discuss two important disorders. One is somatization. Okay. And another is hypochondriasis. Somatization and hypochondriasis. Okay. So somatization is basically patient is preoccupied with somatic, that is physical symptoms. He is preoccupied with somatic or physical symptoms. Okay, so patient will come with complaints. I am having pain at abdomen, I am having bloating, I am having pain in my legs, I am having headache. So the person has visited many physicians, many specialists, nothing has come out. No treatment has worked. So this may be because of some problems in the mind, somatization. Okay, everyone understood? It's not that today the patient has developed symptom, tomorrow I will say it is somatization. No, I will take time. These symptoms should be present for a long time. There should be no other possibility of any other disorder than only. Okay. So one is somatization. Second is hypochondriasis. Hypochondriasis is patient is preoccupied. The person is preoccupied with or preoccupied of having a serious, let me just write it again, preoccupied of having a serious illness. Okay, so here the patient may also complain of symptoms, but here patient will say, doctor, I think I am having a very serious problem. Doctor, I am having headache, I think I am having tumor. Do investigate. Do a PET scan, doctor. Okay, doctor, I am having pain in my abdomen, I think I am having cancer. I am having chest pain, I think I am having a heart attack. Okay, so sometimes patient will say, doctor, I think I am having some serious problem. He may not mention the name. Okay, so are you able to appreciate the difference? Here the patient is only complaining of somatic symptoms which don't have any physical cause. Here patient may complain of symptoms, but he will also mention that he is having some serious illness. So DSM-5 has given a very beautiful name to hypochondriasis. So DSM-5 has given a very good name to hypochondriasis. This is illness anxiety disorder. Illness anxiety disorder. So from the name itself you can see there is anxiety of having some serious illness. Anxiety of having serious illness. Illness anxiety disorder. Okay. So these were the three important disorders which occur because of unconscious symptoms. Okay, so you may get these questions, you may think that it seems to be a medicine question, surgery question, but it may turn out to be a psychiatry question. So be very careful in such questions, especially if they are given in the option that something is there, something fishy is there. Okay, so do have a look. Okay, so this was about these disorders, unconscious disorders. So I think it is 3:30. We'll finish it. Okay, we'll finish it today. So the example was patient may complain of various symptoms, pain. Okay, pain in various parts. Will be preoccupied some illness. So this is somatization and hypochondriasis. Okay, so do revise. We'll let you know about the next session. Okay, few small topics are left. Okay, so do revise. Today itself, do revise. Okay. Shall we discuss the MCQs? Okay, so let us discuss. I think there are only few MCQs which we can discuss. I think one is this. This was 2019. I discussed with you. Always when you are seeing a clinical question, let me give you a trick. Let me give you certain tricks to solve MCQs, clinical ones. First is always try to look for keywords. Not everything is not everything is important. Always try to. So let us see the keywords. A male patient is having had a roadside accident, after which he has fear of driving and going to places. Duration is 6 weeks. He has flashbacks. What is the diagnosis? 6 weeks is very important. But answer will be CBT. In mild, you can consider yes. Okay. Look again, June 2021. Pregnant female on lithium visits antenatal checkup. Greatest risk, abstain and anomaly. Very important. Okay. So again, these are very important. Simple questions have been asked. Okay. So we'll discuss other questions also in our last session. Okay. So continue revising. It doesn't matter how you start, whether you paid attention in your MBBS or not. Finish it like Dhoni. Okay. So all the best. Take care. Yeah.